A very busy day, so we start on time. And I have with me Professor Kailash Mahapatra, sir, who is the president of IAES. Sir, you can inaugurate, formal inauguration will be there in the evening, but still you can make this meeting open, then we start.
Good morning to all of you. It's a great pleasure that the annual conference is going nicely in this beautiful city of Vellore, in this CMC Vellore campus. And yesterday's workshop and all the programs were extremely beautiful, scientific, and enjoyed by everybody. Thank you for the cooperation of the Department of Endocrine Surgery, CMC. So today already is the second day, or the first day of our IAESCON. And with these few words, I welcome you all and wish you your stay and your scientific programs you will go through will be definitely beneficial for all the fraternity of endocrine surgery of our country. Thank you very much, and bye.
Thank you, sir. So we start with blessings from our founder, President, Professor S. Vittal, sir. He has sent a message. I am delighted to know the Indian Association of Endocrine Surgeons is conducting its annual conference in CMC Vellore this year. It is gratifying to note that IAES has grown leaps and bounds since its inception in 1993. I am confident that the enthusiastic group of endocrine surgeons will lead to greater heights. I am sure with the dynamic organizing team, the conference will be a huge success. I pray to the Almighty to bless this conference and participants. May God bless you all. So His blessings are there with us, and we start the first session, the case snippets, and the single one request from my side as honorary secretary is to keep time, because it's a packed day today, and we all know there are so many sessions scheduled. So please stick on to your time. Thank you.
Good morning, everyone. We'll be starting the case-based discussion. So I invite chairpersons, Professor Arvindan Nair, sir, and Professor Venkatesh Rao, sir, on this.
Good morning to everyone. Good morning to our respected chairpersons and dear delegates. My name is Dr. Mohammad Faizal, endocrine surgeon from Chennai. So this is a case scenario. It's actually a granulomas in the background of thyroid malignancy. So we have a 40-year-old male who came to us. He was a right upper limb amputee. It was a workplace accident, so he was out of job. He had a swelling over the thyroid right lobe of 1 year duration. He had a recent onset of bilateral cervical node enlargement. His main concern was the recent onset of lateral neck swellings. So he met a chest physician. He had a FNEC done of the cervical nodes. They were negative for TB, AFP negative, and it came as reactive adenitis. Since the nodes were negative, so he came to us for the thyroid swelling. On examination and history, he had no pain, no compressive symptoms, no symptoms suggestive of hypo or hyper. And there was no history of fever, loss of weight, appetite, or cough or breathlessness. On clinical examination, it was a straightforward right SNT 3 into 2 centimeters, firm, non-tender, moving with deglutition. He had bilateral cervical nodes, levels 3, 4, and 5. It was firm, mobile, non-tender, non-mated, and largest was on the left side, level 4, 2 centimeters. There were no other generalized lymphadenopathy, and the rest of the systemic examination, the chest, abdomen were all normal. So as routine, we did ultrasound neck. The thyroid right lobe had a well-defined cystic lesion, 3 into 2.8 centimeters with a central solid component. There were microcalcifications. The radiologist gave a Thyroid score of 4. The left lobe aneurysmus was normal. Neck nodes, he had a left level 4, 1.6 into 1.2 centimeters, 5A, 5B, all with loss of fatty hilum. There were a few nodes on the right side. Fatty hilum was preserved. So loss of fatty hilum made us suspicious, maybe perhaps it was malignancy. Thyroid score of 4, around 9.5% published malignancy rates as per literature, according to the ACR. So we did an ultrasound-guided FNAC. The right lobe, it came as Bethesda 5, 2 clusters of follicular cells with nuclear inclusions. So they gave Bethesda 5 score. And neck node left level 4 and 5, level 4 right and left, they gave us granulomatous inflammation. No evidence of malignancy seen on the FNAC slides. The chest physician actually asked for a second review of the FNAC slides from another pathologist, and he gave us Bethesda 3 in view of the scanned papilloid clusters, and the lymph nodes came as reactive lymphadenitis. He said there were rare epithelioid cell granulomas. So we decided we will proceed with surgery. So we worked up the patient. Thyroid function tests were normal, chest X-ray was normal, ESR mildly elevated, blood counts were normal, MAN2 was negative. There was nothing on the chest X-ray. So we had a provisional diagnosis of CA thyroid with perhaps infective nodes. We did a surgery with frozen section, total thyroidectomy. We did a CCLND, it was prophylactic, level 6 alone. So the frozen section, we also sent the right hemithyroidectomy lobe. It came as PTC on the frozen. Nodes level 4, right and left, both sent for frozen, came as granulomatous inflammation, no evidence of malignancy seen on the frozen. So the final histopathology was PTC, classical T2 and 0, stage 1. It was a multifocal tumor. T size was 3 into 3 centimeters, right lobe, 2 focus on the left lobe, 0.5 centimeters. Granulomatous inflammation in the central compartment nodes, right, left, level 4 nodes were all granulomatous inflammation. No evidence of malignancy, stains for TB and fungus were negative. The gene expert was also negative. This was the histopathology slides, PAP-CA on the right-hand side, it's papillary projections with nuclear inclusions were seen. Epithelioid granulomas, all of them epithelioid cells surrounded by giant cells. There were no caseation in the granulomas. So epithelioid granuloma as such will look like this with the epithelioid cells and the giant cells surrounding it. Without caseation, this was just a schematic diagram showing the caseation in the middle. So we subjected the patient to radioactive iodine ablation, 30 millicuries was given, and post-radioactive ablation we gave a thyroxine suppressive dose. 2 months after we repeated the ultrasound neck. This was follow-up. He had a small lymph node, 8.8 into 6 millimeters, left level 4. There was no soft tissue in the thyroid bed. His suppressed TG levels at that time, after 6 months, was 0.2 nanograms per ml. So there was nothing suspicious on the lymph nodes. There was no microcalcification, cystic aspect. There was no peripheral vascularity, just for the PGs, hypoacuity and round shape. None of them were there in these lymph nodes. And with an excellent response of TG less than 0.2, we proceeded with a conservative management and kept him on observation. The reason why we presented this was because there are a lot of cases with granulomas in the draining lymph nodes in the background of primary thyroid malignancy. TB is quite prevalent in our country, hence it's considered as the most common cause. However, granulomas are basically non-specific inflammatory lesions. In our patient, TB was not confirmed at any point of time. They can occur also in mycobacterial, fungal, parasitic infections, even other diseases such as Bugenous granulomatosis. In our case, it was a non-caseating granuloma. Most of the reported cases were non-caseating granulomas. Most of them, they're quite rare, but they're reported as sarcoidosis, foreign body reaction, Bugenous granulomatosis, drug reactions, Crohn's, regional enteritis, eosinophilic granuloma, lymphomas. These are some of the most common, but the list is endless. There's an entity that we thought that this patient might have. Most probable diagnosis that we gave for this patient was a sarcoid-like reaction. Sarcoid reaction being a granulomatous lesion similar to that seen in sarcoidosis, but without the evidence of systemic sarcoidosis in the form of lesions in the eye, skin, lungs, or bilateral hilar adenopathy, which the patient did not have, even on chest X-ray. And this sarcoid reaction is associated with various solid malignancies, 4 to 14%, and 4% of thyroid cancers can induce sarcoid reaction. There's no strict criteria. The presence of non-caseating granulomas in draining lymph nodes without hilar adenopathy or laboratory evidence of sarcoidosis is taken as a criteria for making a provisional diagnosis of sarcoid-like reaction. The pathological mechanism of sarcoid-like reaction is unknown, but most probable is the immunological response to tumor-related antigens with release of inflammatory mediators. There was only one publication of a PTC with sarcoid-like reaction, which was published by a Japanese author. They had 5 cases, and it was mostly Japanese patients in 1997. Since PTC has a high propensity for lymph node spread that we all know, almost most of them 20 to 50% can present at time of presentation. They also have micromets up to 80 to 90%. And our patient had a central compartment, the draining lymph nodes, central compartment levels 3 and 4 and 5. So metastasis is mostly common in those areas. So despite the diagnosis of granulomas, these nodes can have in their areas isolated tumor cells. So a close scrutiny of such granulomas is necessary to avoid underdiagnosis of metastatic disease. So to conclude, granulomatous diseases should be considered when patients present with thyroid swelling and cervical lymphadenopathy. Our objective was to advise a thorough evaluation in order to avoid mismanagement of nodes. There are many case reports of nodes being missed in view of granulomatous inflammation and then finally having micromets and recurrence. And sarco-like reactions, even though they rarely reported in thyroid malignancy, need to be considered. Thank you.
Thank you.
Thank you.
That was a nice presentation. We do see, as you mentioned, we do see a lot of associated tuberculosis lymphadenitis with papillary carcinoma. So many times it has come. Very rarely we have seen sarcoid reaction. Other thing, when we have multiple nodes in our country, we think of kikuchis. So sometimes that is associated with different types of tumor in the thyroid. So all lymph nodes, when there are then, of course, first possibility is always to rule out secondary from a papillary, but other conditions also can coexist.
Yes, sir.
Thank you. That's a very interesting topic you brought up, and I think anybody practicing in India will come across the situation. So I would say there are three situations of concern. One is yours, probably a common one, where you have a granulomatous inflammation non-caseating associated with malignancy, and the question is whether to treat for TB or not. And I think, as you said, a lot of the time it is a reaction, and so if you have non-caseation, your cultures are negative, clinically patient is well, we usually say no need to treat for TB, just follow-up. Unfortunately, many people are put on ATT, just looking at the granulomatous report. The second situation would be actually TB in association with. I recently had a case, somebody did a hymethyroid, came back with another recurrent nodule and lymph nodes in the neck. So they thought it was a malignant recurrence. It turned out to be a benign thyroid recurrence with tuberculosis in the nodes.
Yes, sir.
So treated for TB, followed up the thyroid. The third situation, as many of you would have seen, is reactive lymphadenopathy in the situation of Hashimoto's, and that's sometimes also the problem. And when you have a cancer with Hashimoto's, which is getting more and more common, you may have a mix of reactive and metastatic. So we cannot also assume that they are all reactive. So we had both situations. So unfortunately, we are sometimes forced to over-dissect these reactive nodes. So thank you for bringing up this important topic. Well done.
Thank you, sir.
Any other comments from the hall? Yeah, Ritesh, you want to make a comment? Or Dr. Amit? Yes.
Just wanted to share, I also recently had a case of, that was a case of medullary thyroid.
Yes, sir.
It was referred from pulmonary medicine. And she had a lot of lymph nodes, which on cytology was reported as tuberculosis, but I didn't believe because with MTC I would think that it's, and so we did a neck dissection and total thyroidectomy, but it came out to be tuberculosis in the lymph nodes. And thyroid was medullary thyroid.
Yes. Mixed pathology, yeah, exactly.
Thank you, sir.
Thank you so much for bringing this point. Coexistent lymphadenopathy with the thyroid and having a granulomatous disease. Any tuberculosis, lymph nodes, proven tuberculosis, and if it is not resolving with ADT, especially in the setting of thyroid nodule, should be considered as malignancy, because many times in India, cystic lymph nodes are seen in both diseases, and cystic lymph nodes are a semicolon for malignancy in the setting of a thyroid nodule. We had recently this case. Patient was treated for 2 years, recurrent tuberculosis. Not all the lymph nodes were not resolved. Then the patient was continuing. It was a proven malignancy with metastasis. Thank you.
Thank you, sir.
Thank you. That's an additional point. Thank you, Ritesh. So we'll move on to the next. Thank you.
Now I call upon Dr. Farheen Khan to present our case capsule.
Good morning, everyone. Presenting a 17-year-old student who presented to us with bowing of right leg for 3 years duration and associated with bone pains, mostly localized to right knee and leg. And he was diagnosed with genu varus elsewhere for these complaints and was treated with vitamin D supplements and calcium for a long time before he presented to us. Also with a suspicion of osteomalacia, rheumatic osteomalacia. He also underwent corrective knee surgery in 2016. Following this, he had some complaints of bone pains, though not significant enough to hinder in his daily activities. Since the following 2 years, he developed epigastric pain, which was non-colicky, non-radiating, and there was associated postprandial vomiting on many occasions. He was evaluated extensively between 2016 and 2017 with an upper GI scopy, CECT abdomen, which then had reported some lytic lesions in the bones, but he was more on being evaluated on the lines of Langerhans cell histiocytosis. In September 2021, he just had a trivial fall and sustained fracture to the left shoulder and injury to his left knee, following which he went on an arm sling, and at presentation, he could move his arm. In September 2021, there was also an episode of severe epigastric pain with vomiting, and he was found to have acute pancreatitis and was admitted at a local hospital in Lucknow. And during evaluation of that, in the setting of pancreatitis, he was found to have hypercalcemia and a raised PTH. Following this, he was referred to us for further evaluation. On further history, there was no loss of weight, appetite, no history of renal colic, calcaluria, hematuria, no insomnia or irritability, and no visual disturbances, diplopia, or any significant syndromic association history. On examination, there was pigeon chest, there was like pectus cavus, there was significant kyphosis in him, there was features of rachitic rosary, and there was deformity at the medial end of the right clavicle. That was probably a Brown's tumor or a pathological fracture that was healed. His height was 152 centimeters and weight was 34 kgs. He fell into less than 1 percentile of stature and weight for his age. There was scar over the right knee of the previous surgery which was healed, and the genu varus was not very well appreciated post-surgery. Grade 4 power was present in bilateral lower and upper limbs. The movement on the the left shoulder was less than the right shoulder, probably because of the fracture that was present over there. On evaluation, he was found to have severe hypercalcemia with a low phosphate and a normal serum creatinine. His PTH was 134.4 picomoles per liter, and serum amylase and lipase in the range of pancreatitis, alkaline phosphatase of 1335, and a vitamin D level in the sufficient range. An ultrasound of the neck showed 17x6x9 millimeter hypoechoic lesion just below the right lobe of thyroid with internal vascularity, and both the lobes of the thyroid and isthmus were normal. On parathyroid scintigraphy, there was a concordant maybe avid lesion in the right lobe of thyroid, suggestive of a right inferior parathyroid lesion. This is his scanogram. On the left of the screen is the one before his curative surgery with a tibiofemoral angle of more than 6 degrees. It's called Q angle, and that more than 6 degrees is suggestive of a genu varum. And the two pictures on the right of the screen shows, left of the screen shows a picture after his corrective surgery, knee plating. This is his bone mineral density by DEXA, which shows severe osteoporosis at spine -3, a Z-score of -3.7, at hip -3.4, and distal radius -8.4. The corresponding X-rays show significant kyphosis and a rugged jersey spine with areas of sclerosis and osteopenic area in between with wedging of the vertebra. Also on X-ray of the femur and hip, there is severe osteopenia, diffuse, with areas of well-defined lytic lesion in its diaphysis, suggestive of Brown tumors. Also, the hand X-rays show severe resorption of middle and distal phalanges with the presence of Brown tumor in his second metaphalanx. However, there was no features of widening of wrist, cupping or fraying at his wrist, which were not in favor of rickety osteomalacia. On chest X-ray, there was severe crowding, and the distal end of the costochondral junction showed widening, suggestive of rickety rosary. On the left side of the screen is X-ray of the humerus, proximal humerus, with severe osteopenia, loss of bone density, and cortical bone loss with fractures. On CECT abdomen, there was mild evidence of pancreatitis. His diagnosis was primary hyperparathyroidism with severe hypercalcemia, severe metabolic bone disease mimicking rickety osteomalacia post-Genuvaris corrective surgery. He underwent a surgeon-performed ultrasound focused right inferior parathyroidectomy with intraoperative parathyroid hormone assay on 9th of November 2021. Intraoperatively, there was a single lesion consistent with the parathyroid adenoma, and the frozen biopsy confirmed the diagnosis, and there was IOPTH fall of more than 50%. Post-operatively, he developed hungry bone syndrome, and in the initial period itself, he was started with calciums and IV infusion of calcium, and also required magnesium. I'll go on to my next case. So, 16-year-old student in 8th standard presented with weakness of bilateral lower limbs and severe pain bilateral hip and knees. At presentation, she was wheelchair bound, was not able to walk for the last 1 month, and also had history of laparoscopic cholecystectomy done 2 years ago, that is at the age of 14 years, and also was found to have renal stones on evaluation then. There was history of tooth extraction, right lower jaw, following which she noticed a swelling on that side of the cheek. You can see in the picture, there is frontal bossing, there is left eye proptosis, there is swelling in the right mandibular region, and there was a palpable nodule in the neck. Her hands were had significant findings of resorption of distal phalanx. On evaluation, she was found to have hypercalcemia with hypophosphatemia and a high PTH level, and alkaline phosphatase in the range of 6,618. Vitamin D was deficient, and ultrasound showed bilateral renal calculi. Ultrasound of the neck and MIBI scan were concordant for a parathyroid lesion, which was in the right inferior aspect of the neck. Also on the MIBI, if you can appreciate, there is an uptick in her right mandible region on the initial and the washout phases, suggestive of a Brown's tumor. Also evaluated by ophthalmology for proptosis and was advised CT of the skull to look for any Brown's tumors in the retroorbital region. However, because of financial reasons, those were not done. Her BMD score showed severe osteoporosis with minus 5.1 and minus 4 score, with severe decreased density in the spine. There was severe osteoporosis, bilateral fractures of the femur with non-union on the left side. There was severe resorption of the middle and distal phalanx, and there was tufting and resorption of the distal phalanx as well, and middle, and basically the entire skeleton was osteopenic. However, again the wrist joint was normal. Her skull X-ray was had classical feature of pepper pot skull and crew cut appearance, suggestive of severe disease involvement. Also on the skull X-ray, mandible shows osteolytic lesion. On the chest X-ray, there were brown tumor in her femur, and there were widening of the costochondral junctions, and a brown tumor again in the scapula. This is her X-ray of the spine, which also showed bilateral renal calculi, and CT scan of the pelvis showed severe moth-eaten appearance. She was diagnosed with PHPT with severe bone disease and bilateral renal calculi, underwent focused right inferior parathyroidectomy. Her final histopathology was parathyroid adenoma. She had a very stormy post-op period with hungry bone syndrome, again requiring IV calciums. So PHPT is a rare disease in adolescents, and with an incidence of 2 to 5 per 100,000. Usually, adults' presentation with symptomatic disease is only 20 to 50% in literature. However, when children present, it is most of the time symptomatic and very severe disease. The delay in diagnosis and resultant pathologic consequences are because they have very non-specific symptoms such as polyuria, fatigue, poor appetite, weight loss, including emesis in the initial period. And renal and skeletal symptoms vary between 33 and 50% to 16 and 73% respectively. And BMD Z-score does not alone form a criteria to predict fragility fractures in children. However, there is an entity called bone mineral concentration with the 2 standard deviation below the expected label, which is labeled as low for age. So there is a pediatric position development conference which uses one of the following criteria for pediatric osteoporosis. More than one vertebral fracture occurring in the absence of local disease or high energy trauma, or low bone density for age and a significant fracture history, that is defined as more than 2 long bone fractures before the age of 10 years or more than 3 long bone fractures before 19 years of age. So there have been many case reports.
Excuse me, Farheen, sorry,
Yes,
we've
yes.
run out of time.
Okay.
So any small point you'd like to make? And
The take-home message from this presentation should be that children may mimic, the PHPT in children may masquerade as rickets in the initial period, and they are usually treated with vitamin D and calcium, and that is when they present with hypercalcemia. And there are many radiological features that may overlap. So it's a rare situation, but still it has to be, PHPT has to be considered in children even when they have symptoms.
yeah, thank you. Very illustrative cases, and I think we see such extreme cases from Lucknow. It's a very good descriptor. Thank you very much, but we'll have to move on to the next case. Thank you.
A small announcement: if anyone has to load their presentation, kindly come to the preview room. The preview room can be accessed through the left door, the first left door towards your left side. So moving on, I call upon Dr. Muthukumar to present his case capsule.
Good morning, everyone. I would like to thank the organizing committee for giving me this opportunity. So, going on to the adrenal case, this was a 33-year-old female. She presented with the neck swelling for around 12 years with complaints of abdominal pain for around a week. There was no abdominal distension, and there was no symptoms suggestive of hypo or hyperthyroidism, and there was no history of tremors, sweating, palpitations, headache, or giddiness. The patient, otherwise, she did not have a significant history. On examination, the patient was normal. Her BP was 160. Her pulse rate were around 86. All other system examination was found to be normal. So when we examined the neck, there was a swelling of size 9 to 7 centimeters, which moved with deglutition. Trachea was shifted to the left, and the skin or the swelling appeared normal. And on palpation, it was a little hard in consistency, and the lower border was well palpable. There were no lymph nodes. So we went ahead with the investigations. All other investigations were normal. We did a serum calcitonin also, because I'll tell you why we did a serum calcitonin. So with regard to ultrasound neck, we had 8.3 into 7.8 centimeter nodule, which is taller than wider. With few micro-calcification, macro-calcification, they give it as a Tirat's 4 lesion. And since the patient had an abdominal pain, we did a USG abdomen and pelvis. Actually, this USG abdomen and pelvis was initially done outside, and it showed a thick-walled cystic lesion, and it was suggestive of a liver abscess. So outside, what they did was, since they thought it to be a liver cyst, and they did the ultrasound-guided aspiration of the cyst, and it was an hemorrhagic aspirate. And when we inquired the patient, she said she was absolutely fine during the procedure or post-procedure. There was no any untoward incidents during the procedure. And the cytology, they gave it, since it was hemorrhagic, they did a cytology there, and it was inconclusive. So when the patient landed to us with this type, we did a CECT abdomen. It showed a cystic lesion in the liver. Sorry, it was a cystic lesion. It was so when we discussed with the radiologist, they gave it as a diagnosis of a right adrenal cyst lesion. so causing mass effect over the right kidney and segment 6 of the liver. And they said it is not a liver abscess, it is an adrenal cystic mass. So this is a CECT neck, which again they suggested the possibility of a papillary neoplasm. With regard to thyroid evaluation, we did a FNAC. FNAC was suspicious of papillary thyroid. And echo, the ejection fraction was around 60% and they had low cardiac risk. So since it was an adrenal cystic lesion, we measured the serum cortisol, urinary metanephrines, urinary norepinephrines, DHEAs, everything was found to be normal. So we sought a medical endocrine opinion. The patient was evaluated for the BP, supine standing and sitting position. All biochemically it was a non-functioning adrenal cyst. So BP chart was maintained, which was found to be absolutely normal throughout the course of the stay in the hospital. So they said that since the BP is stable and it's a non-functioning tumor, and since it's more suggestive of malignancy of thyroid, so let us proceed for thyroidectomy first. So this was a BP chart. The highest recorded BP at any time was 120/80. So patient was assessed and she was posted for total thyroidectomy. So we thought first we'll do a total thyroidectomy, we'll knock off the thyroid. Then at a later stage, we thought we'll address the adrenal. So on table, the pulse rate and BP was normal. The patient was induced and intubated. Once she was intubated, her BP rose suddenly. It went to around 180/120 to 200/120. And the pulse rate also shot up. Before that, she was absolutely normal. There was not even a single episode of increase in the BP or tachycardia. So we abandoned the procedure. The patient was extubated immediately. We didn't start the procedure. We didn't keep the knife. So post-extubation, after that, the patient developed severe respiratory distress and the saturation also fall with the frothy sputum. So they made a diagnosis of pulmonary edema and the patient was again re-intubated. Patient was shifted to IRCU. So since the saturation was falling even with all supportive measures, the patient, we did a bedside echo which showed a severe LV dysfunction. The ejection fraction dropped to 25%. It was 60% initially, it dropped to 25% in a day actually. So the cardiologist, along with the pericardial effusion, the cardiologist gave a diagnosis of tachycardiomyopathy. Even with all supportive measures, any measures we could do, the tachycardia could not be controlled. So again, medical endocrinology review was sought. So they said biochemically no features of pheochromocytoma, but still clinically pheo. So prazosin was started. Once the patient becomes stable, they said let's plan for adrenalectomy. But what happened was the next day the patient succumbed. We couldn't save the patient the next day, even with all those measures. So the most important component in management of pheochroma is thinking about the diagnosis. So probably we missed the diagnosis. We thought it's a non-functioning tumor. Why not knock off the thyroid first? So I think we should have knocked off the adrenal first. So these are some of the reports or studies showing a non-secreting pheochromocytoma, presenting as insulinoma or cystic pheochromocytoma. All those cystic pheochromocytomas are more prone to be asymptomatic and are more prone to be biochemically negative too. So this was a learning lesson for us. So asymptomatic, biochemically silent, non-functioning, non-secreting pheochromocytoma. So they have no evidence of any features suggestive of pheochromocytoma. So those with the SDHB mutation often can present as non-functioning tumors. They may mimic non-functioning tumors. So subclinical or non-functioning should never be considered safe, and those with the overt clinical patients, sudden hypertensive crisis can also be provoked by catecholamine release. So these are some of the studies which shows about cystic pheochromocytoma. The most of it shows it is asymptomatic and also biochemically negative mostly. So what are cystic pheochromocytomas? Cystic pheochromocytomas is a relatively rare entity, more in women, asymptomatic and a negative biochemical assessment. Radiological features, low attenuation on CT MRI, hyperintense signal on T2 weighted images. They're usually thick-walled with or without a septa with persistent wall enhancement. So it is ideal to do immunohistochemistry by a pathologist to confirm the diagnosis. Unfortunately for our case, we are not able to do autopsy since the patient was really not willing to do it. So of course we know about the paroxysmal hypertension, which can usually hypertension precipitated by certain things like vigorous exercise, sexual intercourse, urination, general anesthesia. In our case, it was the anesthesia which was the cause of this hypertension. So of course, intraoperative management, if suppose a case comes, we all know that we do a CVP, arterial pressure monitoring, avoid the provocative factors. So inhaled anesthetics with the least cardiac depressant effects are always preferred. Antihypertensives should be always be inhaled nitroprusside, nicardipine, nitroglycerin. Tachyarrhythmias to be controlled with esmolol, but in our case, unfortunately, we are not able to control even with esmolol. And ventricular arrhythmias with lidocaine. So after tumor removal, intravenous volume replacement, surgical options always it's in surgery. So after this case, we had another similar case of adrenal cyst presenting similarly without any biochemical features, and it was also a non-functioning. Sorry, it was mimicking a non-functional tumor. The BP was absolutely normal, but we again, because of this incident, we blocked the patient prophylactically with the alpha blockers. But intraoperatively, there was a fluctuation during tumor handling, and postoperatively, there was a drop in BP. So the histopathology came out to be a pheochromocytoma. So the take-home messages would be cystic pheochromocytomas are common. So when present with adrenal cystic lesions, cystic pheochromocytoma should always be considered, and it's a higher probability if patient is asymptomatic with negative biochemical test. Even with the negative biochemical test, it is always better to block the patient before surgery if it's an adrenal cystic lesion. Thank you.
Thank you, Dr. Muthukumar. This is a very common thing we have seen in many of our adrenal cases. I remember way back, one patient was referred as a high dilated cyst of the liver, and from actually Cochin refineries. I still vividly remember the, but she had a huge mass, palpable. But when we did that time only ultrasound was done there. When we did a CT, we found that it was arising from the adrenal. So we took precautions, we did the baseline parameters, and then we took her up for surgery. And this patient, actually, we did an angiogram also because it was a large mass. And then we embolized pre-op and then took her. So the surgery was uneventful. So cystic lesions are very common, and we have seen that many times where they present, pheochromocytomas present with large cystic lesions. Some of them are very functional, very active. Some of them present as you presented, without any symptomatic systems. This lady also she presented as a abdominal swelling with discomfort. And ultrasound showed this, actually it was indenting onto the liver. VMA was not elevated. We did a VMA also for her. No, it was elevated. That's why we did the workup, pre-op workup, blocked and then took her up for surgery.
Very good. Thank you for sharing that. That's a very good of you to do that, and it's a good lesson for all. And we've all been through situations like this. I've been on the reverse side, very small lesion, 2.5 centimeters, but enhancing. But we took up without blockade, had to back out of surgery, go back, did an MIBG. MIBG showed it was hot, and then we blocked and took. We've had neurosurgeons going on, ganglioblastoma lesions without picking up the pheo, had to get out of surgery. We did the pheo, and then they went back. So it's common. But I think the most important thing here is the anesthetist has to be experienced to manage the crisis well. Yes, and that is what determines the outcome. So if you get into a crisis unprepared, then that really requires experienced anesthetist to manage. So thank you for that. Any comment from the floor? Yeah. Yes, Ramya?
No, it can be a normal adrenal cyst, non-functioning, purely adrenal cyst. It can be hemorrhage, pure hemorrhage into a adrenal adenoma with the hemorrhage can present as adrenal cyst. So
parasitic epithelial cysts or something. Yeah. Okay. Thank you very much. We'll move on.
Thank you, sir.
I call upon Dr. Ritesh Agarwal, sir, for his case capsule presentation.
A very good morning to you all. It is always an honor to present in front of my teachers, and thank you organizing committee to provide me this opportunity. So, I am presenting today MEN1 syndrome, an interesting case. I always acknowledge my God, my teachers, my residents, my supporting staff, my family, and always my patient and his family. I had taken permission from the patient to show the photographs, and all photographs are this patient only, without any conflict of interest. A very interesting history, and this is how clinicians, especially endocrine surgeons, should pick up the diagnosis. Young boy, 27 male, working in a MNC, only one symptom, vomiting, which was off and on for past 1 month, came to me because I had operated his aunt recently for primary hyperparathyroidism, and that aunt also had multiple pancreatic neuroendocrine tumors. This one symptom only clinched the diagnosis, and I took the history in detail. He had weakness, flank pain, multiple skin lesions. He went to many other clinicians, gastroenterologists, urologists. Everything was missed. Calcium, very high, 13.7. Albumin, 4.54. Corrected calcium was 13.268. L-phos was high, PTH was high, phosphorus was normal. Our diagnosis was made. Abdomen USG and plain CT KUV, small lesions in the kidney, small obstructive hydroureteronephrosis. With the provisional diagnosis of primary hyperparathyroidism, we further worked up to rule out MEN1 syndrome. So how to work up? ACTH was normal, basal cortisol was normal. ONDST we did because later on we found on CT scan there was a small adrenal nodule also. Gastrin was very high, 58,000. This is first time I have seen the gastrin more than 50,000 in my life. Prolactin was high, chromogranin A was high. Free metanephrines and non-metanephrines were normal. TSH was normal. We did an extensive evaluation. Initially, the basic investigations were normal: liver functions, renal functions, hemogram, cardiac profile, all were normal. Bone mineral density was showing osteoporosis at forearm only, normal at spine and hip. MRI brain was showing pituitary microadenomas. Sonography of neck was showing midline lobulated mass below both lower lobes of thyroid. It was a large mass, non-palpable, 4 centimeters. Systemic B scan was showing an abnormal retention in isthmus in the delayed images. This was the image where it was encircled with red circle. In the red circle, you can delineate the abnormal lesion, a horseshoe-shaped, 3.9 centimeters, hypodense, with a venous enhancement and delayed partial washout. The same in different view. On the same CT scan, we found another thymic mass in the superior mediastinum, which was enhancing in all the phases and with minimal washout in the delayed phase. In this first image, you can see the both lesions, the parathyroid lesion as well as thymic lesion in coronal sections, and in the axial section, the thymic mass. Because he was MEN1 syndrome and chromogranin was high with gastrinoma, so we did a gallium dotanok whole body PET scan. There were multiple areas of high uptake: right upper abdomen, pericable, very high SUV, pancreatic uptake, duodenal D3, neck, pituitary also. Usually pituitaries do not have a high uptake in DOTA, but here it is a abnormal uptake. Many other areas, D2, distal ileum, many lymph nodes, mediastinal, precarinal, axillary, abdomen, neck. We performed upper GI endoscopy. There were thick gastric folds and multiple nodules in the mid-body of the stomach, multiple submucosal nodules in the D1 and D2 of duodenum. We performed endoscopic ultrasonography also. There was a large lesion, 4.4 centimeters, between head of pancreas and IVC. Another lesion superior to this primary lesion and close to duodenum, that was 1.4 centimeters. Multiple biopsies were taken from these endoscopic lesions. Retroperitoneal mass and stomach nodule was showing neuroendocrine tumor grade 1. It was positive for CK, synematophysin, and chromogranin on IHC. Low Ki67 index, only 2%. Other biopsies were normal. Skin lesions biopsy were taken many years back before coming to me. They were proven collagenomas. So with all these workup, we had now a diagnosis of multiple endocrine neoplasia type 1 syndrome, having components of primary hyperparathyroidism, pancreatic neuroendocrine tumor, which is gastrinoma, thymic neuroendocrine tumor, and a pituitary tumor. Parathyroid surgery was done along with the thymic surgery in the same setting. I did parathyroid surgery, and the thymic surgery was done by my colleague, Dr. Amol Bhanushali. Subtotal parathyroidectomy was done. This red arrow indicates the large parathyroid mass, And we did a subtotal parathyroidectomy with other gland removal and biopsies, and VATS-assisted thymectomy. This was whole thymus removed through VATS, and this lesion was the concerned lesion, primary lesion, inside the green circle. Intraoperative PTH was done after removal of all the parathyroid glands, as shown in the surgery. Before incision, it was 466. After surgery, 6.4. Histopath, interesting. The large lesion was adenoma. We had a lot of discussion. We reviewed it. All the pathologists told it is adenoma, not a hyperplasia. However, they found adjacent 5 parathyroid glands, which were very small, 3 millimeters to 1 centimeter, along with this mass. Right superior gland was hyperplastic. Other glands biopsied were normal. Thymic mass, interesting, it is not a neuroendocrine tumor, it is a thymoma, B1. It was negative for synoptophysin and chromogranin. Post-operative course was purely uneventful because it was VATS, so we kept the patient prophylactic in ICU for 1 day. Orally allowed on 1 day, day 1. No significant hypocalcemia and very well maintained on minimal oral calcium and vitamin D supplements. Discharged on day 3. He did very well, and follow-up plan is to do abdominal surgery in December by GI surgeon, radiation therapy for thymoma after that, and serial monitoring of hormonal profile and calcium, and genetic testing. So my question to the audience, this all workup costed patient in a private setting approximately 1.75 lakhs. Had I overworked, or I should have done something else also? So with these questions, thank you so much for pleasant hearing. Thank you.
Thank you, Ritesh. It was a very nice presentation, very unusual combination to get everything at one sitting. I really congratulate you for doing that extensive workup. I think it was worth it because you diagnosed. I still remember Charles Poy used to tell how meticulously he used to open the duodenum and pick out all the adenomas for this. He had a very large series of carcinoids and
Yes, sir.
The tumors of the gastrinomas.
Thank you, sir.
Thank you. MEN1 being the rare disease, it's very good to have a case like that. The follow-up, when have you planned the abdominal?
Dr. Jagannath, GI surgeon, the prominent GI surgeon in Mumbai, he has planned surgery in December because patient is not willing now due to personal reasons. And he's a MEN1 syndrome. We had screened the family also. They have certain issues. Father is having PHPT. Grandfather is having PHPT. Grandfather was operated for neuroendocrine tumor many years back. Many other members. So there are multiple
One
issues.
recent finding, I think, I can't remember where I read it, but the thinking was it was hyperplasia of all the glands, but now they're saying it's most probably multiple adenomas rather than hyperplasia.
One adenoma and other hyperplasias.
Yeah, so it fits in with that. Thank you. We'll move on.
So, but I have a query to the house and to you all, please. Is it worth to do GI surgery?
For the gastrin.
For the gastrinomas.
Generally, that if it's all small lesion and symptoms can be controlled with medication.
See, multiple tumors throughout the stomach, duodenum, and pancreas, as well as uptakes on DOTA in axillary lymph nodes, mediastinal lymph nodes, and abdominal lymph nodes. So will it be worth really?
The thing is that the main aim is to reduce the tumor bulk. So the large palpable ones you remove whichever are there, and then you reduce the tumor bulk, and that way medical management becomes more easy.
Okay, sir. Thank you so much. Thank you so much, everyone.
Thank you, sir, for the presentation. Now I invite Dr. Suganya to present her case capsule.
Good morning, everyone. I'm very happy to be here, seeing everyone after a long time. I'm happy to present in front of my teachers. So I'm going to present today about the neuroendocrine case capsule. I'm restricting myself to the pancreas, as neuroendocrine tumors can occur throughout the body. So starting with the patient with multiple endocrine neoplasia, the background of multiple endocrine neoplasia, how difficult was it to treat the neuroendocrine tumors of the pancreas. So this patient of us presented with a history of hypoglycemia, diaphoresis, palpitation, and tremors. They can also present with as severe symptoms as seizure and coma. She had it in fasting state. History of syndromic feature is she had been operated for brain surgery for microadenomas and macroadenoma in the brain, and also for parathyroids. She is not a known case of diabetes. So history taking in hypoglycemia is very important because in OPD, when a patient presents to you with hypoglycemia, first important differential diagnosis we should think is of her, we should take her drug history, because it is mostly patients with sulfonylureas who present with hypoglycemia. So other history, we should be careful to find about the critical illness and alcoholism. So investigation, when a patient has a documented low blood sugar level, which is being cured by giving oral glucose to the patient, that is a Vittal steroid. If we are not having the documented blood sugar, we can provocate it by doing the 72-hour fast test. So this test should be done in a controlled environment with an IV access ready to give glucose. So our patient was positive in 1 hour. She presented with hypoglycemia, and serum blood sugar, insulin and C-peptide should be done when a patient is having the hypoglycemia episode. So why we are doing C-peptide is, C-peptide is formed during the formation of insulin. So when C-peptide is high, we can rule out the exogenous cause where C-peptide can be normal. So in our patient, insulin and C-peptide was high. So going on to the investigation, where blind procedures has also been done for insulinoma in previous years. So thanks to the advent of CT with multiple thin slices, what she had was multiple tumors in the pancreas. We did extended scan, which is a glucagon-like peptide 2 scan, which showed those tumors were functional. So now she is in hyperinsulinism due to the neuroendocrine tumors, multiple neuroendocrine tumors of the pancreas. If she has a solitary tumor, we would resort to surgery, but for her, when there are multiple tumors, first option should be medical management. So starting was the diazoxide, which was escalated to higher doses. She did not respond to, hence we have given octreotide short-acting 50 and increased to 100. With this also, she responded for some time, and then she had multiple episodes of hypoglycemia, around 20 episodes, which are because of the tachyphylaxis of octreotide, which was not acting now. So option of total pancreatectomy was discussed, but total pancreatectomy is such a morbid procedure leading to the patient to brittle diabetes. Options are discussed with the patient. So case 2, he is a male with no functional syndrome history. He presented with abdominal pain. On CECT, he had a solitary lesion in the head of the pancreas, which was close to the duct with no metastasis. The endoscopic ultrasound and biopsy was done. In a neuroendocrine tumor, what we will find is a group of cells which will be arranged in fascicles or in a trabecular pattern. So on high power, what we can make out is a rounded nucleus, conspicuous nucleus with a salt and pepper chromatin. So it was, IHC was positive for chromogranin and synaptophysin. Serum chromogranin was high, but serochromogranin can be elevated in other situations also. So it is not a good diagnostic marker, but can tell us the burden of the disease. So thanks to our medical endocrine and surgical gastro team who helped us in managing the case. So this is a tumor of the pancreas, which we have done Whipple's procedure. This is a residual pancreas with a feeding tube in the main pancreatic duct, and the vessels are looped. So histopathology was neuroendocrine tumor, grade 2. So case 3, this is a young female who presented with abdominal pain. She has been evaluated outside and she was given medication, did not subside. Ultrasound was done, and later with CT, unluckily she had multiple tumors in the pancreas with multiple liver mets. Serum chromogranin was high. Dotanok PET showed metastasis in the liver. Not only in the liver, she also had bone mets and also had metastasis in the breast, which is a very rare site. So our CT-guided biopsy was suggestive of neuroendocrine tumor. So for her, what can we give is a long-acting sandostatin. She is responding with it. So in the literature, what else can we do to the patient is, non-functional neuroendocrine tumors are common than the functional neuroendocrine tumors. They present late to us because of the symptoms, late symptoms, and they always present with a large tumor and metastasis in most of the case. But grade 1 and grade 2 tumors are slow to grow, hence they can have a good 5-year survival rate. So neuroendocrine tumor basically is a cell which releases endocrine hormones and respond to a neural stimuli. It can occur diffusely in any organ like the medullary carcinoma, thyroid, pheochromocytoma and paragangliomas are all are neuroendocrine tumors. Neuroendocrine tumor is rising. It is now 6 in 1 lakh. So, but previously used carcinoid tumor is no longer used because carcinoid term itself will not tell the exact malignant potential of the tumor, and also the carcinoid syndrome which we read, it is mostly it occurs in GIT and lung tumors and not in other areas. So it has been evolving neuroendocrine classification. Recently in March 2022, WHO classification is based on the nuclear features Ki67 and mitotic rate. So well-differentiated tumors have been called as neuroendocrine tumors. A tumor which is poorly differentiated is now called as neuroendocrine carcinoma, and it is also divided into small cell and large cell tumors. The presentation, as we said, it can be functional syndromes or also because of the anatomical pressure effect and metastatic symptoms. Functional syndromes are many depending upon the origin of the site, depending upon the hormones which they secrete, like in, Sir said, in gastrinoma, peptic ulcers, glucagonoma, necrolytic migrating, erythema, somatostatinomas and VIPomas. Diagnosis is by combined histopathology, imaging and biochemical markers. So treatment as such, when it is localized, we can cure the patient by doing complete resection. Metastectomy can also be done when it is a localized disease. So what is the role of debulking cytoreductive surgery is only when we are able to remove 90% of the tumors, especially in grade 1 and grade 2, it has shown to increase the longevity of the patient. Otherwise, debulking surgery is not useful. What other therapies can we give in neuroendocrine tumors are? We can concentrate on the somatostatin receptors, target them and give octreotide analogs, give lutetium therapy. What else is we can give also everolimus targeting on the mTOR pathway and sunitinib and interferons and bevacizumab depending upon the progress of the disease. Commonly used somatostatins, they are used mostly for low-grade tumors. They show good result in low-grade tumors but not in the high-grade tumors. But they can also, they are tolerated good, but they can also have tachyphylaxis. So our choice of treatment depends upon the whether the disease is localized, whether it is low-grade, you can start with somatostatin analogs. When it is progressive, you can switch on to everolimus and sunitinib. When it is widespread, then the last resort would be chemotherapy. Thank you.
Thank you, Suganya. I think the first case, it looks quite straightforward. It needs surgery.
Yes,
We
but
definitely.
discussion of total pancreatectomy was
We don't need total because your GLP positivity is in the tail and body.
body and 3 regions, 3 tumors. Tumors in the uncinate and in the body and in the tail.
So you know the classic Thompson procedure, we do a distal pancreatectomy and enucleate the head lesion. So that has been done quite safely. Definitely, I think that case you should consider.
I think that I also agree that that should be treated. The important thing is sometimes the worries of pancreatic fistula, and we always do, just take a rule loop and put it on there, you won't have a pancreatic fistula. So still it is worth, because the medical treatment, one is expensive, long drawn, and results are not very good. So the large lesion resection and enucleation is a viable option.
Second, I think the decision on Vittal, sorry, I missed the size of the tumor and the location.
Size is 3 into 4 centimeters.
In
Close
the,
to the duct.
Abutting the duct, yeah. So that's a rare situation, and if you feel that you can't get, then you do a Vittal. Yeah, any point from the floor? Otherwise, we'll. Yeah, thank you very much. It was
Thank you,
very
sir.
descriptive and good guideline when in trouble what to do.
Thank you.
Thank you.
We have now completed the first session of the day. I thank Dr. Arindana sir and Dr. M.J. Paul sir. Coming on to the second session of the day, to chair this session, that is on lectures in endocrine surgery, now I invite Dr. Amit Agarwal sir and Dr. Kailash Mahapatra sir on stage. Karthikeyan, who will be at the reception. Now I call upon Dr. Pradeep PV to present his lecture on Papillary micro-carcinoma revisited.
very good morning to all of you. So, Dr. Pradeep, you may start.
Good morning, everybody, respected chairpersons, dear friends and colleagues. And at the outset, I would thank the organizers for this opportunity to present on a topic which has now become relevant. Why this has become relevant is because the WHO classification of thyroid tumors in 22 has removed this term, papillary microcarcinoma. Now, what they mentioned there is that all incidental and occult papillary carcinomas are not equal, and the terminology is misleading for the patients as well as the treating clinicians. And hence, the size alone deciding the prognosis is unscientific, and therefore, it is taken off from the 5th edition. So that's what they mentioned. Now, for that, let's go to the background, a little bit to the background. If you see that early when the ultrasounds and the FNACs were introduced, they found that the incidence of thyroid malignancy rose by about 2.4 to 2.9 folds in US. That is during the period 73 to 2009, and 15 folds in Korea. And in Japan, the study showed that 3.5% of the Japanese women, more than 30, are showing thyroid carcinoma, which is less than 15 mm. So similar phenomenon were observed in all other countries. So the thyroid malignancy was being picked up more and more. And in general, it was realized that the prognosis is good for papillary thyroid carcinomas, except for a few subtypes, like the tall cell, the columnar cell, and the oxyphil variant. Most of them are having a very good prognosis. So, and it was also realized that these are slow growing, they have got good outcome, except for this small group, and high risk can be identified, and therefore they can be managed in a better way with aggressive follow-up and a better treatment. So much so, the studies at that time showed that for papillary carcinoma, whether you do hemithyroidectomy or you do total thyroidectomy, everything is same. The results are the same. The overall survival is 99% in one for hemithyroidectomy, 100% for total thyroidectomy, not much difference. And they were large case series followed up for many years, even up to 20 years. And they also showed that the mortality and distant metastases were all not different whether you are doing a minimum surgery or an extensive surgery like a total thyroidectomy. Similarly was the recurrence rates. And some studies even said that for a low risk, you don't even have to do radioactive iodine therapy. So everything boiled down to the tumor size. If you look at the tumor size, you see that if it's a T1 disease, the recurrence is 6%, 5-year survival is 100%. But as the tumor size increases, the prognosis gets affected. And that's what was all these scoring patterns showing. The mass is scoring, the Lahey scoring, ages scoring, everything was showing that the tumor size is an important prognostic factor. And the TNM also, you can see the recurrence rate is 15% if the tumor stage is 1, that is a T1 lesion. So, when all these things were coming up on the background, this micro-carcinoma was introduced in 1998, in the 2nd edition of the WHO classification, because the lesions are less aggressive, the distant metastasis is exceptionally rare, and it's an incidental autopsy finding in many series, and up to 35% in Finland. So it was felt that the evidence justified separating papillary microcarcinomas from other clinically evident lesions, like the other types of papillary carcinomas, the larger ones. Even though papillary microcarcinoma does not depend on whether a lymph node metastasis or a distant metastasis is present, it just depends on the size, it was considered that it was a less aggressive tumor. And so much so, some studies even mentioned that the term carcinoma is a harsh and severe term, and it leads to emotional and physical responses from the patients. And some study even said that later on into 2018 that let us change it to pre-cancer. All the PMTC should be changed to a pre-cancer lesion. Simultaneously, when this microcarcinoma came up, many took up this active surveillance in papillary thyroid microcarcinoma. But those main advocates of these are from the Japanese. Ito, Miyauchi are the groups which advocated for this. They had a 10-year follow-up of over 1,200 cases, and they showed that the tumor enlarged in only 8% and 3.8% developed nodal metastasis. I think this also influenced the ATA subsequently, and they said that don't have to do FNA if the lesion is less than 10 mm. Virtually means that even if it's micro-carcinoma, you can follow up, ratifying the studies of Ito and Miyauchi. And the reason was mentioned there was that Americans are unlikely to opt to follow up if they are known that they are having a carcinoma. So they don't do FNAC. So if you don't do FNAC, you don't have to follow up a microcarcinoma. But similarly, at that time itself, articles were coming up saying that all PTMCs are not same. A patient can be followed up, but there are separate subgroups. They can be an ideal patient, they can be an appropriate patient, or they may be inappropriate patient for follow-up. And this was published in Endocrine Practice. If you see the active surveillance, all publications are from Japan. They influence the ATA also. But in their publications itself, they have said that PMC is likely to progress if the patient is young. And most of our papillary carcinoma, microcarcinoma patients are young. So many of them will be excluded from follow-up. It is likely to grow. If there are BRAF and TERT mutation, it is likely to have an aggressive behavior. Remember, we are not able to do all these mutations in most of our patients. And tumor nearer to the course of RLN, they said you should remove it. Now, that is very subjective, depending on the radiologist and so many other people to define this criteria. But PTMC is not so indolent. We have seen from our experience, especially from the surgical side, the surgeons would have experienced that it is not so indolent. And that is documented in various studies also. It's very aggressive in some cases. No definitive biological or clinical parameters exist which can distinguish a low-grade PTMC from an aggressive one. And it is said that the palpable metastatic node in many case series, and in your personal experience also you would have seen that the palpable nodes are the first point from which you start investigating and then find that it is due to a micropapillary carcinoma. It's also documented that 60 to 80% of the papillary thyroid microcarcinomas have nodal disease. And this, remember, the nodal disease determines the prognosis in papillary thyroid microcarcinoma. And the accuracy to pick up this node in an ultrasound is very low. The incidence of nodal metastasis has been documented to be around 55% if the tumor is less than 5 mm and 73% if it is 5 to 10 mm. And so, the most unfavorable feature of an aggressive PTMC is in fact not picked up by our preoperative ultrasounds. Also remember, PTMC can be classical type, that's well and good, but it can also be a tall cell variant, it can also be a sclerosing variant, so they can be aggressive variants. And PTMC can have multifocal disease as with a normal PTC also, it's to the tune of 28 to 46%. And that is considered to be a tumor which cannot be followed up. Just one or two cases which we recently experienced. This is a 79-year-old male. He had a routine health checkup at Mumbai, and health checkup, I don't know how it included a PET CT, and the PET CT was also done. They found a nodal mass in the left level 4 region, and an ultrasound was done where you can see that it's a 3.9 into 3 mm lesion, a TR4 lesion. Since there was nodes lung nodules in the PET, FNAC was done, it's showing papillary carcinoma of the thyroid. And this node, you can see that the thyroid is very, very normal there. You can hardly make out the microcarcinoma on the left side. But the lymph node, you see the lymph node here, that is infiltrating the the internal jugular vein. And we had to remove the jugular vein also to get clearance. The node could not be separated from that. So a microcarcinoma, but presenting with nodal mass first, which has infiltrated the internal jugular vein. This is the biopsy. You can see the biopsy is a classical papillary thyroid carcinoma. It's not even the aggressive ones. And it's a 4 mm lesion. And the lymph nodes are positive. Another patient, 39-year-old patient who has been repeatedly visiting psychiatrists for his anxiety-related symptom. He had an irritant cough. So they underwent a CT thorax, which suggested lung nodules, which soft tissue, you can see the lung nodules present in the CT chest. And therefore, he was worked up. And on part of the workup, you can see that there is a thyroid nodule, which is T4. Again, it is TR4. They are not saying it is TR5 or 6. You can see a 9 mm lesion. And this FNAC is suspicious of papillary carcinoma thyroid. This patient is awaiting for surgery now. This is one of the largest series which I came across on papillary microcarcinoma. You can see 704 patients. In this, very interesting points are mentioned. You see, they have, in this, for extrathyroidal extension was seen in about 46%. Multifocality was in 32%. The stage at presentation was stage 3 in 23%, stage 4 in 14%. And so it shows that many of these patients have aggressive lesion to begin with. So I think the microcarcinoma, telling it as microcarcinoma and following and advocating a milder approach, maybe sometimes under-treating a disease which could have been very well managed, even otherwise. So overall, PTC is a cancer with a good prognosis. We all understand that. We all appreciate it. But as with all malignancies, subgroups with even better prognosis are listed out in this. That's also okay. The realization that size is an important prognostic factor initially had led to identification of microcarcinoma. However, cases of distant metastasis and regional metastasis are very well reported. Regional nodal disease is an important prognostic factor for PTMC, which, however, is difficult to pick up, especially in the central compartment by our ultrasound. So for a malignancy which has even better prognosis than the parent papillary thyroid carcinoma, the larger one, in general, a justification for delaying diagnosis and treatment is questionable according to me. WHO classification now removes PTMC and advises PTMC to be typed as any other PTC so that the prognosis can be accurate and these patients can be managed in the microcarcinoma stage itself. Thank you very much.
Thank you, Pradeep, for your talk on a very contemporary and a controversial topic, And whenever I travel across the world, the question is asked, why can't we do an active surveillance in India for papillary microcarcinoma? And I think you would agree, unless you have a trained radiologist and a pathologist who can rule out, extrathyroidal extension or a multifocality, it will be very difficult to do active surveillance for papillary. And as you rightly said, we have to treat them as a conventional papillary carcinoma. And as wonderfully shown in your case, they can be very aggressive, So I think outside Japan, there's only one center in Europe and US who follow an active surveillance for PMTC. But as for now, I think outside institutions, it will be very difficult to do a conservative program for a microcarcinoma. So to my mind, I think they need to be treated as like any other conventional papillary carcinoma. So any questions and comments from the House? Yes.
Okay. See, if you go by recommendations, probably they will say that these patients don't even need a diagnostic whole body radioactivity scan because it's a microcarcinoma and you have done an R0 resection. And the stimulated TG is within the normal limits. But for our practice, what I'm doing is we will definitely subject the patient for a diagnostic radioactive whole body scan after the surgery. And also look at the thyroglobulin and antithyroglobulin levels. If the diagnostic whole body scan is negative and TG, ATG is acceptable, normal, then there is no radioiodine therapy. But I think this is a controversial thing. The institutions may have different approaches to that, but I take a general safe practice approach, so I do this.
Any other question? Yeah, Ranjit.
Yeah, that's also a good approach. But at the initial go, when you have two sets of investigations saying that there is no metastasis, like one is the diagnostic scan, second one is the TG, both of them added together, I feel that is more sensitive. And I can declare the patient that, okay, you are free of this thing, and now I can follow up the patient without any scans later.
Thank you, Pradeep. Can we? A quick question, yes, Pooja.
They said subtyping has to be done as per the counterparts as the regular PTCs. So we don't have to use the term microcarcinoma.
Yeah, I think last slide Pradeep mentioned that it's removed from them.
Yes. So that's what I'm saying. It's probably delayed a little bit. They should have done it earlier.
Yeah.
Okay, can we?
0.5 centimeter ischemic nodule with multiple central compartment nodes. Unfortunately, guided FNAC was showing Bethesda 3 classification in fine needle aspiration cytology. Nodes, as my pathologist told, it most probably PTC metastasis. But the central nodal burden was too high, and the age was around 75 years. So my first concern was is it a PTC, 0.5 centimeter, Bethesda 3, metastasizing to central compartment, or because he was 75 years?
No, just one thing. The central compartment is a clinical, ultrasonographic finding, or you have pathology there? You have FNAC there?
Both were there. Both were there.
So FNAC from central compartment is papillary metastasis, and the FNAC from the thyroid is Bethesda 3.
3.
Okay.
And the more concerning part for me was going in and taking it out, and the nodes turning out to be some other metastasis, because reliability of the pathology is always questionable. So what is as you mentioned, is it advisable to go for a PET-CT before surgery in these cases? Normally I won't do PET-CT before surgery, but this was one case I preferred because the nodule was smaller and node burden was high. As you mentioned, it is a papillary micro-carcinoma.
So the post-operatively histopathology is...
No, pre-operatively, because my concern was...
So pre-operatively you have a Bethesda 3 lesion as per the FNAC report and metastasis in the central compartment node, which is from papillary carcinoma. There is no need for PET. You do the ultrasound evaluation of the neck, and then you go ahead and do your total thyroidectomy, central compartment clearance, and then based on the TG and other findings, you go ahead like any other thyroid cancer.
The only thing is
Aramal will go to the next. This time is short actually. Thank you, Pradeep.
Thank you, Pradeep.
It was
Thank you.
excellent.
Thank you.
Thank you.
Now I call upon Dr. Dhalapathy Sadacharan sir to give his lecture on neonatal severe hyperparathyroidism.
Good morning, everyone, and I will thank the organizers for the opportunity. So now we will be talking about a rare scenario of primary hyperparathyroidism in a neonate, which is an autosomal recessive disorder which causes a life-threatening hypercalcemia. As we know, this is an inactivating mutation, homozygous mutation in the chromosome 3 of a calcium sensing receptor gene. And we know that it has a long amino terminus, which is a thing, and a venous flight trap structure, which is the extracellular domain, and a 7 transmembrane domain. So there is the calcium sensing receptor senses changes in the circulating calcium, and it inhibits PTH secretion and increases calcium excretion in the kidney. So there are more than 250 different mutations. There are gain of function mutation as well as loss of function. When there is gain of function mutation, there is various degrees of hypocalcemia is observed, and there will be abnormally low PTH, and the calcium can be normal or elevated. But when there is loss of function, if it is a heterozygous mutation, we get the familial hypocalciuric hypercalcemia, where the hypocalciuria will be there and the PTH will be normal or inappropriately high. And mild hypercalcemia can be there. But our setting is a homozygous thing where we get this neonatal severe primary hyperpara, where the calcium set point is high, leading to PTH secretion and increased renal absorption. So coming on to our topic, it can present usually within a week. Usually they present with failure to thrive. That is the most common presentation of this type of neonatal setting. They will have muscular dystone, hypotonia will be there. Few will present with respiratory distress because of this. And constipation is usually invariably will be there in these infants. So associated abnormalities which can be there would be a deformed chest or dysmorphic facial features can be there. Skeletal abnormalities can be there with sometimes with osteolytic fibrosis cystic also. But it's very difficult to find out in an infant all these things. So biochemically, the main thing is we need a good neonatologist or a pediatrician to suspect hypercalcemia in this setting when they neonate present with the failure to thrive. That is they are the crucial persons to get the cases. So they will have a severe hypercalcemia in the range of around 20 to 30. Most of our patients which had calcium around 30. Majority of our neonates had calcium around 30, and the PTH will also be elevated to the around 5 to 10 fold times. So with this, relative hypocalciuria will be there. Intraoperatively, which I will be showing, the parathyroid glands can be normal or maybe minimally enlarged. And whatever the imaging which we do in adults will not be helpful in this setting. And early diagnosis is critical. And again, I reiterate, the treating neonatologist or the pediatrician is the crucial person to diagnose this case rather than any imaging. So when we find or diagnose a case of neonatal severe primary hyperpara, we need to be managed medically before the kid is ready for surgery. So it includes intravenous fluid hydration, diuretics, calcitonin, bisphosphonate, cinacalcet. We have used cinacalcet in a baby for more than 4 years. So when the oldest kid which I operated was around 4 years, and during this 4 years, the baby was on cinacalcet and was maintaining calcium around 14 to 15. So this calcium mimetic can bind to extracellular domain and most helpful, useful in heterozygous mutation. And homozygous mutation, as we see here, are usually unresponsive. And the surgical options is the thing which is the treatment for cure. And what is advocated is a total parathyroidectomy to make the baby aparathyroid so that they will not have recurrence when we do a subtotal parathyroidectomy. Autotransplantation is an option, but the thing is, risk of persistent and recurrent disease is there, which I have not exercised in this. So, as such, till date we have encountered 7 such cases which have been operated, and all of the patients underwent genetic testing, except one patient. So, 6 patients had a homozygous calcium sensing receptor gene mutation, and out of these, 2 had novel mutations also. All these had a Sesame B scan also done as part of their academic workup, which was negative. So this will be the thing. What we do is a total parathyroidectomy and a transcervical thymectomy. So we do remove the thymus to remove any supernumerary parathyroids which can be present also. So we did publish our 4 cases, which was done previously. And regarding the 7 cases, we have a long follow-up of more than 11 years, which was done in 2012, actually 11. So we did all of the 7 cases, 1 case had a failure. That was in 3rd case, where you can see the calcium was around 20 to 30 in majority of these cases. It was near 30 in all these cases. And all patients, we took it for a total parathyroidectomy and a cervical thymectomy. But the 3rd case, you see, we could find only 3 parathyroids. So one side we could find 2 parathyroids, the other side only 1 parathyroid. So I had to do a hemithyroidectomy also on the right side, thinking that maybe the parathyroid would be intrathyroidal also. But the thing, in spite of that, the PTH was still high, and the calcium was around 13. But it is still manageable. The baby is on cinacalcet for the last 5 years. So it's still doing well also, in spite of 3 gland parathyroidectomy. And other last one we did 4 months back, a total parathyroidectomy and cervical thymectomy was done. Majority of these patients, you see, they had a failure to thrive. And PTH was near thousands, actually. So the number of parathyroids, all had 4 parathyroids. One had a supernumerary parathyroid, the second one. So one baby, the 5th baby died actually. That is not due to the neonatal thing, but the associated, the baby had a pulmonary hypoplasia also. So postoperatively, they could not wean out of the ventilator. So the baby succumbed to that. So I would like to show a few videos. This is the first case of neonatal severe hyper, which we operated some 11 years back This was the oldest baby which we operated. At the time, the baby was around 4 years. So normal 4-gland exploration was done. All the carotid sheath were open to look for the supernumerary parathyroids, all those things. So you can see the nerve, and you can see the, so thymectomy was also done. In babies, when we do a thymectomy, you have to be very careful when we pull out, because the vein and the SVC can be pulled out because it will be very friable. So we have to be very careful when we deliver these things. This is the normal looking parathyroid only. But the thing is, the fat is less, there is no fat at all. So this was the supernumerary 5th parathyroid which was there in this baby. So this after surgery. So this is another baby which was operated at our 1.5 months of age. The standard procedure was done. Mobilization of the sternocleidomastoid, opening the carotid sheath to look for from the angle of the mandible up to the clavicle, and to look for the retrotracheal as well as the retroesophageal space also. So you can see the parathyroids, just crystal clear actually. There's no fat at all. So you can see the nerve very well here. This thymectomy was also performed along with it. So not this one. This was the last case which we operated 3 months back. It was around 1 month old. So actually all concern has been taken from the parents to show the videos of those things. And I would show, this is the video of a boy which we operated 10 years back. This was taken 3 years back, the video. He is doing very well and he is going to school also. So with this, I would like to thank my endocrinologist, my pediatrician, neonatologist, and my residents for helping me find these cases and operating. Thank you very much. I'd be happy
Thank
to
you.
take any questions.
Thank you, Dr. Dhalapathy, for an excellent, I think it's a very difficult operations operating on, and your videos support the concept that endocrine surgeons are the best surgeons to operate on pediatric thyroid and parathyroid tumors. Any questions and comments? Ranjit?
I have experience only with one patient. I didn't have an intraoperative PTS for
I have not used in these patients.
Okay. Is there any literature say?
The thing is, actually, even the calcium in these neonatal cases, unlike adult cases, they start to fall very late. Unlike the adult cases where we expect immediate fall, the calcium also, it started falling after 24 to 48 hours. So to have a normal calcium level itself, we have to wait for at least 4 to 5 days in these patients. I have not done IOPTH in any of these patients.
Okay,
I don't know whether it will be useful or not.
That's an interesting question, because the whole purpose here is to make the children aparathyroid, So perhaps an IOPTH value of 0 will give you an idea that all parathyroids have been removed. Yes.
Sir, do you do a frozen section regularly, sir?
Pradeep, do you use loops or by naked eye?
No, sir, I don't use loops, sir. I have not used loops, sir.
Were they really difficult to find the parathyroids?
Yes, sir. It is as normal as in the adults.
Especially they don't have fat, so you can
yes,
easily...
It will be actually easier than in
adults.
Yes, sir.
Sir, do you do a regular frozen section, sir?
We have not done any frozen.
Because one case we did neonatal parathyroid.
When we have any doubt only, we will be doing a frozen section. But we are confident that it is a parathyroid with the location and these things. So we didn't have that thing to do that also.
So what about the post-operative course, sir? Because one patient, we had a very stormy course. We had to put the patient again on ventilator. We had to wean after 3 or 4 days. So regarding experience on the
actually,
post-operative
these patients, when we
course,
take up for surgery, they will be, most of them will be on ventilator only. So
yes,
post-operatively, they will be under the neonatologist or the pediatrician for 1 or 2 days in the ICU setting only. So the calcium, as I said, it will start falling. Unlike start with 24 hours here, it will start falling by 48 hours. So the PTH, it will be normal. Maybe we have not done IOPTH, so we do the PTH on the next day only. All these cases we have done like that only. But calcium definitely takes time to fall.
sir, we had a fall only after 4 or 5 days only.
That's what I'm telling. It takes time, unlike a normal adult case where we expect a fall within 24 hours.
They're also in the kidney, probably.
Yeah, it will be there, Ranjit.
Thank you, Dr.
One suggestion, why don't you pool these cases? People are doing at different places. So being the rarity of things. So what is how many cases you have done?
We have 7 cases operators.
Nice, thank you very much.
Thank you.
Now I call upon Dr. Anand Mishra to give his lecture on adrenal incidentaloma, what's new.
A very good morning. Thank you. At the outset, I would like to thank the IAS Scientific Committee for giving me this opportunity to speak. So my topic is adrenal incidentaloma. What's this new in this disease? I bring greetings from my university. So we all know that incidentaloma is defined as any inapparent adrenal mass in a patient who is being investigated for some other reasons. And this excludes these cancer patients or patients who are the investigation being done for staging. Now, the most common, we all know that these incidental-lomas are non-functioning, around three-fourths of them, and then followed by functional group. Cortical secreting adenomas are more common. Now, question is what to do in these non-functional. So my talk will be devoted to most of these non-functional, what should we do, and what is the natural history in these patients. This is the other differential diagnosis, rare type of adrenal incidental-lomas. So the treatment, if I say, just summarize in this slide, is guided by a detailed history and physical examination and followed by certain clinical radiological features and biochemical assessments. And these biochemical assessments are mandatory in these all patients. Certain biochemical, we have to do a cortisol, plasma ACTH, aldosterone ratio, and then we have to see the medullary hormones. Now, one entity which is most important in these cases in nowadays is autonomous cortisol secretion or hypercortisolism, subclinical hypercortisolism. And I'll be discussing this issue. And the diagnosis is made by, there are certain criteria. How do we make these autonomous cortisol secretion? And all patients who are functional, they need to be operated. All patients who are malignant or appearing malignant on radiology, they need to be operated. So indications are, the fixed indications, well accepted indications are any size, if size is more than 6 centimeter, they are functioning, malignant or symptomatic, you need to operate these patients. And on CT scan, if there is a delayed washout of contrast, less than 60%, that becomes also an indication for surgery. And any patient who are during the follow-up, if size is increasing, and that is more than 0.8 centimeter increase in 3 to 12 months, or 20% increase in size, that becomes also a relative indication for surgery. Now, so if I summarize the various points, what's new in these adrenal incidentalomas? Present day, the incidence is increasing, and it is because we have higher resolution investigations, more sophisticated investigations. And there is also a reason that there is increasing trend of use of these radiological modalities in all the diseases. And then the second issue is what should we do when a patient, how to diagnose, and what should we do when patient has mild autonomous cortisol excess or subclinical hypercortisolism in these patients. And then because of this, there has been also a proposal of new name nomenclature in these patients, non-functioning. What should we do if we have a bilateral incidentaloma, adrenal incidentaloma? What is the role of PET-CT, certain new investigations and ongoing trials? So I'll be concentrating on these, just touching these points. So prevalence is around 1 to 6%, and if you see, it is by abdominal CT around 4 to 4%. It has been recently, it has been increasing, and if we compare in last 3 decades, it has increased up to 10 times. It increases with the age also. The next issue is autonomous cortisol excess. What it does, what is the problem? Now, with autonomous cortisol excess or subclinical hypercortisolism, there is a number of morbidities which are associated: hypertension, obesity, intolerance, dyslipidemia, or osteoporosis. And certain retrospective, one of the retrospective studies, they have associated more deaths, and which is related to cardiovascular reasons in these patients. Now, what should we do if patient has mild autonomous cortisol excess, whether we should go for surveillance only or ilectomy? And that answer only we can get if we know the natural history of these patients. So the data is very limited. There is only one randomized trial, control trial, which can give the answer. And in this randomized trial, we have that answer that it improves the type 2 diabetes, it improves the hypertension, it improves the hyperlipidemia, but there were no change in bone measurements. And then there are a lot of retrospective data available, but that is limited only. If you see, these are certain studies which have all retrospective data, and post-operative we see improvement in arterial hypertension, we see improvement in weight, and we see improvement in impaired glucose metabolism. So bottom line is, if there is hypercortisolism, subclinical hypercortisolism, and you see that your patient is not very morbid, you can go for adrenalectomy in these patients. Then let's see the natural history of adrenal incidentoma, which are non-functional or have mild functional. What happens to their in the natural history? So it is a meta-analysis, and we see that some of the patients, very little, less than 0.1% of patients, they progress to overt Cushing's syndrome. Some patients of these have develop this mild cortical excess, which are non-functioning, and less than 0.1%, they become, in fact, this mild cortical excess, it becomes spontaneous, they have spontaneous resolution. The another question is what happens to the size? And there is one study which says that size increases during the, in longer follow-up, size increases in these non-functional tumors. And risk of developing these autonomic cortical axis has been associated with three factors. If adenoma is more than 28 millimeter, if they are bilateral adrenal tumors, or low or suppressed ACTH values. This has been associated with risk of association of AC during the follow-up. So on these basis, a new nomenclature in fact has been proposed. It says that for non-functioning adrenal incidentallomas, this should be the name, adrenal lesions of undetermined secretion of adrenal steroids. And there are various arguments why we should give this name, although this is not an accepted nomenclature, one paper says. So this is the only, and then what should we do when a patient has bilateral adrenal incidentaloma? If there is a bilateral adrenal incidentaloma, it indicates a strong genetic predisposition. Maybe it is associated with various familial syndrome. Two of the genes, NR3, C1, ARM3-5, these two genes have been found associated. And this NRC, if it is heterozygous, it has mild glucocorticoid resistance also. What should we do if there is a bilateral adrenal incidentaloma? Some of the studies say that you should do only when there is overt Cushing syndrome. Then only you should go for bilateral adenectomy. Otherwise, you can choose a unilateral adenectomy in these patients if they have subclinical hypercortisolism. And in fact, they say that if you do only unilateral adenectomy in these patients, you operate only one side, these patients do improve during the follow-up in various parameters like diabetes, hypertension, or lean body mass. So this was a paper, what is the effectiveness of unilateral operation in a bilateral adrenal lesions, and it is a retrospective analysis. They have done, seen the conservative versus operation, and in our unilateral group, they have found that it improves AC, autonomous cortical axis in these patients. Now, there are certain new tests which has been applied in these patients, and it is HPLC method, high resolution HPLC method, mass spectroscopy of urine. And the metabolite is THS, tetrahydroxycortisol, and it is a very strong indicator of ACC. So it has a great diagnostic potential. And since we are using urine for testing, so it is a less invasive and less costly method, non-traumatic method. And another study, it was found very high sensitive and specific for the ACC. So this test can be used, and by that, we can predict that this patient maybe in the follow-up will have ACC. There is another study, urine ACT study. It was a validation study done in 2,169 patients, and they have applied a triple strategy of combined tumor diameter, positive imaging characteristic, and urine steroid metabolism, which we were topping. And if you combine these three parameters, the positive predictive value of ACC is around 76%. So this strategy can improve detection time for these patients for which we can take a decision for surgery. The next issue is, what is the role of FDG PET in these patients? So primary role of FDG PET, we all use it as in cancer patients for metastatic workup. So it helps in extraadrenal metastatic disease, which was not detected on CT or MRI. It can, yes, differentiate between a metastatic disease from a benign disease of unknown malignancy. And if SUV is more than 5 or 5, and adrenal to spleen or adrenal to liver signal ratio is more than 1, then it is suspicious category. And in these patients, one can consider adenectomy, or one can go, if it is non-functional, do a biopsy, and then take a decision. Or you can keep these patients under active surveillance, and then you can again check these patients after 6 months and 1 year, and then take a decision. The sensitivity and specificity for specific things are low. directly, I mean, you can not use all these patients, subject all patients to FDG PET, but in certain situations, you can use FDG PET judiciously to take a decision in these patients. So, there are certain new tracer agents which has been used in just besides FDG. So carbamidate, and it has a very high accuracy rate for lateralizing aldosterone secretion tumors for consanguinoma, but it has low half-life. Another agent, 18F labeled MTO, it has a longer half-life tracer, so more selective. Then 123 iodine labeled, another metabolite, it permits high specific characterization for adenocortical tumor, so it has low radiation, that's an advantage, low radiation exposure. Another agent, dopamine analogs, or one can use this MIBG tagged PET. Another investigation which is new, has been used by the radiologist, is CCT, contrast enhanced CT, textural analysis in addition to the radionomics. And MR spectroscopy also has a role in differentiating between adenoma and pheochromocytoma by choline and creatinine ratio. One can calculate and then predict whether it is adenoma or pheochromocytoma. There are 2 ongoing trials whose result will be having later in 2024 and 2022. So impact of adrenal incidental-lomas and possible autonomous cortical secretion on cardiovascular metabolic alterations. That's one study. We don't have the early results. Another study, structural evaluation of adrenal tumors discovered incidentally, prospectively imaging the testing yield. These are the 2 new trials which are undergoing. Maybe these trials give us some more knowledge after 2 years. So with this, thank you, and I'll be happy to answer any questions. So that was all, something I could find in the literature, new things regarding adrenal incidental-loma.
So I think for practical purposes, if you do a washout study and combine it with the size, you have a scoring system which gives you a sense. So this is commonly which we use in our practice. But as you rightly mentioned, I think the point to take home is the triple test, is very important, urinary metabolites and steroid metabolites. That's a very upcoming test, and I think soon this also will be used in practice. So I think you touched some very recent advances in management of adrenal incidental-lomas, which will be useful to the audience. Thank you.
Thank you.
Any questions? Any questions from the audience?
So literature says that it is more useful, but I think availability will be one issue. It is not available. It will be available only in big centers, and I mean specialist centers and big centers, and availability will be more issue. And then there are papers that it is more useful. Yes, I agree.
Thank you, sir. Anand, you have thrown a very much of light on this topic, which is really emerging and as you said, the diagnosis as well as management is very difficult in these cases. I think the newer modalities, as Amit said, I think things will be more clear. Thank you very much for your nice presentation.
Thank you.
Thank you.
The next lecture is on Insulinoma, What's New? I invite Dr. Manish Kaushal on stage for this.
Good morning. Thanks to the Indian Association of the Endocrine Surgeon for giving me the opportunity to present Insulinoma, What's New. So, as we understand, Insulinoma is the most common functional pancreatic and neuroendocrine tumors. And mostly this tumor, the size is less than 2 centimeter, well circumscribed, and mostly these tumors are the benign. The incidence is 1 in 1 million, 1 to 4 per million, and it represents 1 to 2% of all pancreatic neoplasm. So mostly these tumors are the benign. Only less than 10% of the tumor are the multiple and malignant. And most of these tumors, they distributed equally throughout the pancreas. So insulinoma located in the pancreas, but in some insulinoma, ectopic insulinoma can be present outside of the pancreas in the duodenal wall. So in the recent advances, the investigation part I will discuss in the two important studies that I found in the later. So we will discuss what the current standard practice. The current standard practice is the intraoperative localization. So the two important part of intraoperative localization, one is the digital palpation and another one is the ultrasound. We can support by intraop glucose monitoring, intraop insulin assay, and frozen section. So because this tumor, there is pseudocapsule is there, mostly solitary. So most surgical choice is the enucleation. But in cases where the enucleation is not possible, then we can proceed for the pancreatic resection, which cure rates around 85 to 95%. So enucleation is mostly performed open technique, but because we have now the good facilities of the laparoscopy, and it can be safely done by the laparoscopic technique. So in the most cases, it's a benign tumor, so no lymph node dissection is required. Come to the intraoperative palpation. The technique is very simple. It's enter the lesser sacs, expose the pancreas, and mobilize the pancreas. Palpate the different regions of the pancreas. If it's a insulinoma, usually you can palpate as a firm nodule with a soft parenchyma. But there is a limitation where we, and in cases of the fatty pancreas, patients have a previous attack of the pancreatitis or tumor situated in the deeper portion. These limitations can be overcome by the use of the intraoperative ultrasound. So in intraoperative ultrasound, this ultrasound should be done by the 7.5 to 10 mm transducer. And initially we scan longitudinally and consider positive if the sonolucent mass detected in the both transverse and longitudinal imaging. So intraoperative ultrasound identify around 90% of the insulinoma even without the palpation. It's also help us the relationship of the tumor to other vital structure like pancreatic duct, splenic vessels, common bile duct, and superior mesenteric vessels. If we support with the palpation and along with the ultrasound, we can even our judgment is up to 100%. So other adjuvant technique we can use intraoperative glucose monitoring and intraoperative insulin assay, which also help us to remove this tumor. Apart from the enucleation, we have an option of the pancreatic resection. So different type of the pancreatectomy possible for the removal of the insulinomas. Now come to the open technique, open enucleation technique. In open enucleation techniques, mobilize gastrocolic ligament, enter in the lesser sacs, retract stomach and omentum, and expose the pancreas. Inspect for any tumor. After locating the tumor, incise very thin tissue over the tumor and dissect tumor gently. Remove a rim of the surrounding pseudocapsule, and after completion, do intraoperative ultrasound to find integrity of the pancreatic duct. If suppose tumor is very near to the pancreatic duct, means it's away from less than 2 millimeter to 3 millimeter, in that cases we can go for the pancreatectomy. Now come to the open technique, minimally invasive. We can go for this rather than open, we can proceed for the laparoscopic technique. And early experiences with the laparoscopy showed a successful rates of the pancreatic enucleation and distal pancreatectomy. More recent studies in the efficacy of the minimally invasive pancreatic surgery demonstrate that the laparoscopy, distal pancreatectomy, and enucleation of the insulinoma is safe and reduce the hospital stay. Now, laparoscopy enucleation technique, usually position is dorsal decubitus position, 4 to 5 ports, and stomach lift by the atraumatic forceps. So this is just, we go through what is the standard laparoscopic technique to remove the insulinoma. Opening the gastrocolic ligament, remove the posterior gastric wall adhesion, retract stomach by the retractor, then exposure of the tumor. enucleation by the hook, bipolar cautery, or other energy devices. Create groove all around the tumor. So removal of the all deeper adhesion carefully. Removal in the endobag, hemostasis, and mild compression. Drainage tube in the retrogastric position. We can, apart from the enucleation, we have a full basket of the different type of the pancreatectomy in cases of the multiple insulinoma or in cases of the insulinoma very near to the pancreatic duct. Apart from the laparoscopic surgery, now recent trends for the robotic surgery. So robotic surgery is widely accepted in different specialties, including the pancreatic surgery. And what is the benefit compared to the laparoscopic surgery? The robotic surgery is the approach at lower rate of the conversion and higher rates of the splenic preservation. But the problem is robotic surgery, it's a higher cost and lower because it's a availability, it's a big issue. Post-operative complication because of the enucleation, the chances of even the actual formation of the pseudocyst, pancreatitis, intra-abdominal abscess, development of the diabetes, and pancreatic fistula. So most common complication in insulinoma surgery is the pancreatic fistula. Now come to just a few words of our series. We have 7 cases in last 15 years. So these are the 4 females and the 3 males. Youngest patient is 17 years old and 54 years is the eldest. So all patients presented the neuroglycopenic symptoms with the symptoms of the weakness, seizures in few patients. So in our series, we performed 4 cases open enucleation technique. In 1 cases, we performed a distal pancreatectomy. In initial part of our career, we performed 1 case in a blind distal pancreatectomy, where we couldn't localize, and this patient lost in the follow-up, and this is a failed surgery. We considered as because the patient is not, the insulinoma tumor is not found in the distal pancreatectomy. In last 4 years, we found only 1 case of the insulinoma when we performed the laparoscopic enucleation. This is the 1 case of the insulinoma present in the uncinate process of the pancreas. CT scan performed, and its size is less than 2 centimeters. So this is the tumor location. Exposure of the tumor. All cases we have to go for ISC confirmation. This is another case where we performed the insulinoma resection in the tail of the pancreas. Now come to the 2 important studies because we are dealing with the what's the insulinoma new. So one study, it's a study in the, which we are 79 patients. In this study, they have a data from 1980 to 2010. So total 79 patients. The most beauty of this study, the initial part of this study, the only imaging studies only detect 39% patients. And later on in 2000, they detect 2000. In 2000, they detect around 98%. So the first part of this study from 1980 to 1989, total number of overall imaging studies detect only 39%. And at that time, they also performed the transhepatic portal venous sampling. The result is around 75%. Later on, they couldn't perform the transhepatic portal venous sampling. Endoscopic ultrasound, it's a modality they performed in between this group 2000 to 2010, and they found it's a 82% the sensitivity. So overall the detection is 98%. So this is the beauty of this study, and more and more cases in this new group, 43 cases. In this study, the surgery, they performed the enucleation, distal resection, and pancreatectomy, but there is no difference between the age different group. In all group, the enucleation and distal resection is the same. Now come to the another study. This is very good study because it's give the results on the minimally invasive versus the open treatment for the benign sporadic insulinoma. So in this study, they have a around 71 cases of the enucleation. And 71 out of 71 cases, we found there are 6 cases they performed the laparoscopic enucleation after 2012. So every 3 years, they have a make different group. So in a recent group, there is 6 patients out of 15 patients that laparoscopically, they performed the laparoscopic enucleation compared to the formal pancreatectomy. Around 50, out of 15 patients, 11 patients they performed laparoscopically. So this is a trending change in the trend. So more and more new techniques, laparoscopically, robotic surgery used in the management of the insulinoma, either enucleation or formal pancreatectomy. So post-operative, pre-operative localized benign insulinoma should be approached laparoscopically or if technically it's feasible. So it's a well-standard fact. So in insulinoma, where the surgery is not possible due to the medical reason, benign cases, non-surgical ablative therapies are available. There are, in this study, we have around, we can see this is 44 cases, 26 cases, ethanol injubulation, and around 7 cases tumor embolization, 7 cases radiofrequency ablation, 1 case is the irreversible electroporation, 1 case is percutaneous microwave ablation, and 2 cases ultrasound ablation. So these are the different techniques, new techniques they perform for the where the surgery is not possible. So in those cases, we can go for the ablation therapy. But in this series, they performed only 1 case of the percutaneous microwave ablation. But later on, I found that there are many case reports of the microwave ablation therapy in the insulinoma patient. So these, what are the risks of these minimally invasive procedures? Minimally invasive procedures localize abdominal pain, mild pancreatitis, and duodenal ulceration. And it's higher incidence of the pancreatitis. But if most of the pancreatitis is if we give the insulin injection more than 2 ml. Pancreatitis due to the microwave ablation or radiofrequency ablation is rare and self-resolving. So compared to the open techniques, the chances of the pancreatitis is less. A word about the insulinoma in the MEN syndrome. MEN syndrome, insulinoma present symptoms earlier, and these tumors are frequently multiple and higher recurrence rate. Despite to failure the MEN mutation in 10 to 25% cases, genetic testing is important. Now, in those cases where we can't perform the surgery in malignant insulinoma, there is a medical management with the everolimus. Everolimus is rapamycin analogs, and it is a very promising drug in cases of the unresectable insulinoma. So there are many articles of the case reports, use of the everolimus. So finally, the take-home message, imaging sensitivity is improved. Now more and more cases of the insulinoma, pre-operative we can localize. Because of the development of the energy sources, and now every center have the facilities of the laparoscopy, and more cases we offered laparoscopic removal, and some center, those who have a robotic facilities, they offer the robotic surgery. Increased role of the non-surgical ablation therapies for the benign insulinoma. On those cases, those who are surgery refractory, we can't perform the surgery, we can go for the non-surgical ablation therapy. Thank you very much.
Thank you, Manish. Thank you, Manish, for talking on insulinoma. Though it is not, commonly seen in our practice, but I think you have a modest experience of those. How many? 7 cases you had, yes. So, any questions from the house? Comments and questions?
Manish, how could you diagnose this benign insulinoma, that ablative therapy that you said restricted to the benign ones? How can you know that?
Sir, usually every patient go for the metastatic workup because we perform any liver mets or any other type of the chances of the metastasis. Then this is the first thing in the imaging we rule out. Although insulinoma malignancy point of view for the pathologist is big, bigger challenge. It's a more towards whenever you remove, it's a pseudocapsule is there, and it's a completely, it's a remove smoothly. It means it's a 100% chance of the benign sporadic benign insulinoma, because it's a solitary. Metastatic insulinoma is adhered with the surrounding structures, and on imaging it looks like chances maybe it's a malignant one. Difficult to operate.
Yeah, I think size, if it is more than 2 centimeters, or if it's irregular border and adhered to the pancreas. So your question is pertinent because you have to really show that you're dealing with a benign lesion before you go in for a non-surgical ablative.
Ablative therapy, you have to confirm first
Yes.
that it's a benign.
Thank you.
Thank you, sir.
This, we end this session. Thank you very much.
Thank you.
Thank you, Kailash sir and Amit Agarwal sir, for chairing this session. The next session is Orations in Endocrine Surgery. For this, I invite Dr. Sabaratnam sir for introduction of Professor S. Vittal Oration.
We all know about Professor S. Vittal Oration. Professor S. Vittal is the father of endocrine surgery, and sir has contributed immensely to the field of endocrine surgery in India. And it's my proud privilege to present about Professor S. Vittal. He's a Padma Shri awardee, and he's the founder president of IAES, Emeritus Professor of Surgical Endocrinology, Tamil Nadu, Dr. MGR Medical University, past president of Association of Surgeons of India. And great man, he was born in Tiruvallur in 1941. He has outstanding undergraduate and postgraduate teaching from Madras Medical College. And he has done his UG and PG from MMC and MS from Madras Medical College in 1967 and FRCS from the Royal College of Surgeons of Edinburgh in 1974. He is instrumental in development of endocrine surgery in India. He created the first department of endocrine surgery in India at Madras Medical College. And he played a pivotal role in the development of endocrine surgery in other institutions as well. And he is known as the father of endocrine surgery in India. And he was the president of Association of Surgeons of India in 1998. He was the president of International College of Surgeons, Indian session from 2000 to 2002. He is a founder president IAES from 1993 to 95, honorary secretary of ASI from 1992 to 96, and past chairman of Royal College of Surgeons of Edinburgh Indian chapter, surgical tutor and examiner for the Royal College of Surgeons Edinburgh. And he has delivered the many prestigious orations, Colonel Pandalai Oration of ASI, Ginde Oration of ICS, and BJS Oration. And he has authored a textbook on surgical endocrinology. He has been editorial board member of several journals like British Journal of Surgery, International Surgery, Indian Journal of Surgery. He has been a teacher for more than 6 decades and active member of ASI for more than 5 decades now. And he has many awards like Dr. B.C. Roy National Award in 1995, Tamil Nadu Scientist Award in 1998, Overseas Gold Medal from the Royal College of Surgeons Edinburgh in 2005, and the Teachers Award in 2007. Lifetime Achievement from the Chief Minister of Tamil Nadu in 2010, and Padma Shri in 2011, and Lifetime Achievement Award from ASI in 2012. And even Lifetime Achievement Award from Tamil Nadu and Pondicherry chapter of ASI in 2014, and Doctor of Science Honoris Causa in 2014 by the Tamil Nadu Dr. MGR University, and Lifetime Achievement Award from the News 7 channel in 2000. And here we can see the inauguration of the surgical endocrinology at GH in Madras Medical College, first of its kind in India. B.C. Roy Award in 1995, Overseas Gold Medal Award by the Royal College of Surgeons of Edinburgh, FRCS, Padma Shri in 2011, and Lifetime Achievement Award of ASI, and by the Pondicherry and Tamil Nadu and Pondicherry chapter, and by the Tamil Nadu Dr. MGR University DSC in 2014, and Lifetime Achievement by News 7 channel in 2019. He is happily married to Mrs. Rajkumari and blessed with three illustrious children. His scholarship, irradiation combined with humility has ended him to everyone in the medical field. This oration has been instituted to honor a great teacher and an excellent surgeon who's the father of endocrine surgery in India. Thank you.
Thank you, sir. Now I invite Dr. M.J. Paul for introduction of orator.
It's my privilege to invite Professor Frederic Triponez from Geneva, Switzerland, to deliver the S. Vittal oration. He is head of the Division of Thoracic and Endocrine Surgery and the Department of Surgery at University Hospital in Geneva. Frederic finished his medical school in Geneva in 1996 and then completed his general surgery training there before he went on to spend a year in Lille with Professor Charles Poix and another year with Professor Orlo Clark in San Francisco. When returning to Geneva, he developed the endocrine surgical unit, making it the biggest center for thyroid and parathyroid surgery in Switzerland. He also specialized in thoracic surgery and spent 2 years in training. He was appointed head, as mentioned, and his current areas of research relate to the development of innovative techniques to preserve the parathyroid function during thyroid and parathyroid surgery, aiming at decreasing post-op hypoparathyroidism. Of special and personal note, I encountered Frederic when we were both fellows in Lille. He was a senior fellow, like a senior registrar, when I was training, and Charles Poix was the head. You can see here actually taking first laparoscopic adrenalectomy experience abroad with Frederic operating. And the last picture is Frederic actually did the last operation with Charles Poix when he ended his career. So we had a wonderful time at Lille, and I must say that he is such a wonderful person in the family as well. You can see, shows his role with Anaik, his wife, and 3 children. They've spent a wonderful life together. And these are some of the pictures that show this. So Frederic, thank you for being here. It's an honor for all of us to listen to you talk about your experience with hypoparathyroidism. Thank you.
Dear colleagues, I'm Frederic Triponez from the University Hospitals of Geneva. Dear Paul, dear colleagues, it's a great pleasure to share with you some thoughts on the use of fluorescent technique in thyroidectomy. Unfortunately, I was not able to make it to Vellore, but I'm sure that you are having a wonderful congress. This presentation is pre-recorded, and if everything works well technically, I will be live for a question and answer session at the end of the presentation. So I share my screen. As you probably all know, parathyroid glands are the last organs that have been discovered, first in a rhinoceros, unicorn rhinoceros, in a London zoo, when this rhino died after a fight with an elephant, apparently with a rib fracture. The conservator of the London Zoo did a dissection, and he found these new organs next to the thyroid gland that, of course, were bigger in the rhinoceros than in the mice or even in the human. And this was in 1862. And then these parathyroid glands were also discovered in man. And then people needed almost 50 years until they understood the function of the parathyroid glands, and they discovered what was their role regarding calcium regulation. In 1908, these authors wrote that all violent symptoms produced by parathyroidectomy may be almost instantly cured by the intravenous injection of a solution of calcium salts. So they understood the acute condition led by parathyroidectomy. apparently the parathyroids control in some way the calcium metabolism, similarly to diabetes. Tetany might be spoken of as a diabetes calcareous. So at that time, they understood the acute condition of hypoparathyroidism, but then others needed time to understand the chronic conditions of hypoparathyroidism. And at the same time, or similarly, surgeons understood that it was very important to protect those organs, and not only the parathyroid glands, but also their vessel, in order to avoid those catastrophic results after thyroidectomy with damage to the parathyroid gland. So on the long run, chronic hypoparathyroidism is a severe disease that leads to different complications, including cardiovascular complication. I just show you here a result of a cohort study analyzing 8,000 hypoparathyroid patients, most of them after thyroidectomy, compared to 40,000 control patients or controls. And in this graph, you see that the combined cardiovascular endpoints were more than doubled after 5 years in patients having definitive hypoparathyroidism. Regarding renal function, you see that half or twice as more patients with hypoparathyroidism develop chronic kidney disease in the hypopara group, and twice as more patients develop end-stage renal disease as compared to the controls, also over 5 years. Our Scandinavian colleagues also have demonstrated in a cohort of patients with chronic hypoparathyroidism that the risk of death was doubled in patients with permanent hypoparathyroidism as compared to control. So this is the burden of chronic permanent hypoparathyroidism, and on the other hand, it's probably more frequent than expected or than described. If you look at numbers coming from experience center, the rate of definitive hypoparathyroidism are usually described to be between 0 to 3%. However, if you look at rates coming from registry-based data, it's more around 10% in North America, in UK, in the Scandinavian registry, and in the German registry. So the disease of permanent hypoparathyroidism is more severe than expected and is more frequent after total thyroidectomy than usually thought. So we need two parts to preserve the parathyroid glands. One, you need to locate them, to know where they are and to find them. And the second part is to preserve their vascularization. So regarding the localization, as you know, the localization of the parathyroid glands depends on their embryology. And the superior parathyroid gland has a different descent than the inferior ones. Usually, parathyroid glands are described as a standard location in anatomical study, but as you know, they are found in different locations, and their location is quite variable. Here, it's a pretty recent surgical study, and if you look at this 2 by 2 square centimeter, and you will find most of the superior parathyroid gland in this 2 by 2 square centimeter. However, you will find a significant proportion of them outside of this 2 by 2 square centimeter. And the same is true, or even more true, for inferior parathyroid gland. If you look at this square of 2 by 2.5 centimeter, most of the parathyroid gland, inferior parathyroid gland will be found in this square, or it's not a square, a rectangle, but you will find a significant proportion of the inferior parathyroid glands outside of this kind of standard location. And so you know that the standard location of superior parathyroid gland is here, the standard location of inferior parathyroid gland is larger because of their more variable and more way to descend from their fourth branchial pouch. So once again, it's important to preserve the parathyroid glands, to know where they are, but also to preserve their vessel. And coming back to the Halstead study, he already described different vascularization pattern, and this is his original drawings that you can find in his article. And you can see that most of the parathyroid glands are already described as a cherry on a stem with a very fine vascular pedicle, some being easy to preserve during thyroidectomy and some being more difficult to preserve. You can imagine if you do a thyroidectomy here, it's not that easy to preserve that inferior parathyroid gland with its vessels. There are other anatomical studies showing the same. I just show you a few anatomical specimens from Jean-François Delattre, also described as a cherry on a stem, where you see the parathyroid gland with a tiny vessel feeding it. And you see one easy example, a right thyroid lobe here that is medialized. The recurrent laryngeal nerve is here. Inferior thyroid artery is here. And you see that the inferior parathyroid gland is here. Superior parathyroid gland is here. And you see that in this example, in this specimen, it's very easy to do a total thyroidectomy, preserving both parathyroid glands with their vessels. In this example, on the other hand, it's on the left side. Left thyroid lobe is medialized here. The recurrent laryngeal nerve is here with two branches, and you see that both parathyroid glands are pretty far away from the thyroid lobe. Inferior is here, superior is here, but they have pretty long vessels running very close to the thyroid gland. So even if it's easy to do a thyroidectomy, letting or leaving both parathyroid glands inside the patient, it's very easy to damage both of their vascularization. And so the anatomical study I have mentioned to you before also described the vascularization pattern and different vascularization pattern. Most of the vascularization came from the inferior thyroid artery, some from the superior thyroid artery, sometimes with anastomosis between these two arteries, but there were also some different vascularization pattern coming directly from the thyroid ima artery or directly from the thyroid gland. This is another way to show the possibility to preserve the vascularization. This is a Chinese study, and you see that if you have a parathyroid gland in this position, it's easy to do a thyroidectomy preserving the parathyroid gland and its vessel. If it's a B1 position, it's possible if you try to preserve the parathyroid gland and the vessels, and then for B2, C, and B3, it's getting extremely difficult to preserve the parathyroid gland and their vessels. In this study, it has been shown that it was almost impossible to preserve the parathyroid gland with their vessels in 25% of the parathyroid glands. So we are going to talk about autofluorescence. So autofluorescence is the spontaneous fluorescence of the parathyroid gland. Nothing has been injected here. And ICG angiography, ICG is indocyanin green. It's a dye that you inject and with which you can evaluate the perfusion. What is fluorescence? Fluorescence is the capability of a substance to be excited. So if you excite one of these electrons at a given wavelength, this electron will go into an excited state. And when going back, or here, when going back in its ground state, it will re-emit a light with a little less energy because it has lost some energy here. So less energy, higher wavelength. So the excitation wavelength is smaller than the emission wavelength. This is the principle of fluorescence. Fluorescence can happen in every wavelength, UV, visible light, near infrared light. If it happens in the UV to visible light, you can make something invisible to human eye to something visible. For instance, here it's quinine. Quinine is fluorescent in the UV range. So if you excite quinine with a UV laser, you will make it blue because before the UV you don't see it with the naked eyes, but then it will re-emit a light with a longer wavelength, less energy in the blue range that you will be able to see. So it's the same principle, but we will use in the near infrared range. Why? Because it's very useful in human usage, because it has less absorption by blood and water, and because it has some possibility to go to a certain depth. So, for instance, you will be able to see indocyanine green through the vessel wall, because you can have some at least 5 millimeter of depth of penetration. Autofluorescence of the parathyroid gland has been discovered about 10 years ago by a team in Nashville, in the United States. Lisa White was a surgical resident at that time, having some troubles finding the parathyroid glands. And Anita Mahadevan Jensen is a biophotonics engineer at Nashville. And they published their preliminary paper in 2011, where they could analyze 21 patients, and they could demonstrate that the fluorescence intensity of the parathyroid gland was 2 to 11 times higher than that of the thyroid. They confirmed these results in 256 patients, and this is a typical example. So if you excite the tissue in the neck at 785 nanometer, then at 820 you will have a high peak of fluorescence by the parathyroid gland. Usually that is much higher than the fluorescence intensity of the thyroid, fat and muscle. This is one example, but every patient is different, and in some patients the difference of intensity of the fluorescence between the parathyroid gland and thyroid is very high, up to more than 20 times, and in some patients it's less. But in most of the patients, in almost all patients, the autofluorescence intensity of the parathyroid gland is higher than that of the thyroid. So this is autofluorescence. A few video examples. So you have here a right thyroid lobe that is medialized into Babcock clamp, and you see both parathyroid gland, the superior parathyroid gland here, the inferior parathyroid gland here. The inferior parathyroid gland is still a little bit embedded into thymic tissue, and therefore it's a little bit less autofluorescent than the superior one. However, you can still recognize it. You also see on this video that you have some false positives. So, for instance, Vicryl suture is positive. I use Vicryl suture to retract the upper flap, and here you see Vicryl suture is fluorescent. Another example here with color. So you are on the left side. This is the left thyroid lobe that is medialized by my assistant, and you see that the superior parathyroid gland was here, and as usual, or as can sometimes happen, the inferior parathyroid gland was hidden by my assistant, who did a good job retracting that thyroid lobe. But then when taking out the sponge, you can see this autofluorescent spot that was not clearly visible with the naked eye. Once again, the standard standard color view here, not that easy to recognize that parathyroid gland, but easy to recognize with the help of autofluorescence. People use also artificial intelligence or computer to help detect those parathyroid glands, and I just show you this article because I think it's quite interesting. It's a you look only once principle. So they evaluate tissue, and then the system gives you the probability that it is indeed a parathyroid gland or not. So the system is able to detect parathyroid gland with standard RGB view, but with adding autofluorescence to that, it gives you a higher confidence that it is indeed parathyroid gland. In this example, 81% here, but 96% with the aid of autofluorescence. And therefore, it seems to demonstrate that autofluorescence is really useful, not only for the human eye, but also for artificial intelligence. They are able to recognize parathyroid glands more easily than with naked eyes only. We still do not know what is the fluorophore, so what is the substance responsible for this autofluorescence property. What we know is that diseased parathyroid glands are less autofluorescent than normal ones. And if you look at primary hyperparathyroidism and parathyroid adenoma, you will see that the standard view looks like this, with the part that is more autofluorescent than part that is less autofluorescent here. We call this part the cap. And when analyzing these different parts, here again, a strongly autofluorescent part and a less autofluorescent part. And if you analyze it with histology, it will always be the part that is the rim of normal parathyroid tissue that is more autofluorescent, while the adenoma part is less autofluorescent. Of course, something you should also know about autofluorescence is that it is resistant to devascularization, heat, and fixation. So this is a piece of laryngectomy. After laryngectomy, parathyroid glands are still autofluorescent, as here. And even after formalin fixation, here, parathyroid gland, thyroid gland, even after formalin fixation, the parathyroid gland remain autofluorescent. And therefore, parathyroid autofluorescence does not give you any clue about the parathyroid viability, but it just tells you that it is parathyroid gland. There are some limitations, and one of the limitations that you should be aware of is that positive lymph nodes in the central neck are sometimes also autofluorescent. So in this, for instance, central neck dissection specimen, you see many autofluorescent spots. Sometimes it's not very easy to detect the parathyroid gland inferior, usually parathyroid gland in that specimen. Sometimes it still helps you, but you have to be careful for positive lymph nodes. So to summarize on autofluorescence, it can help the surgeon identify parathyroid gland in real time. It has a high sensitivity. Most parathyroid gland will autofluoresce more than the thyroid. However, it has a lower sensitivity for abnormal parathyroid gland, adenoma, and hyperplasia. It has a lower specificity. Other structures can autofluoresce. However, most of them are easily identified by naked eyes, for instance, vicryl suture. And very important to know, it does not help predict parathyroid gland viability. Some limitations, there are some false positives I have mentioned. The signal is non-standard, so the autofluorescence intensity between parathyroid gland and thyroid is different from one patient to the other. And it cannot be used after ICG injection because the remaining autofluorescence or the remaining fluorescence signal from ICG is too strong. You will not be able to detect the autofluorescence signal that is less strong. So why can you or should you use our autofluorescence for the localization of the parathyroid gland? Because we think that if you know where they are, it's probably easier to protect them during dissection and or to reimplant them if they are localized on the specimen, of course. For the confirmation that the tissue is indeed a parathyroid gland, it gives you confidence about the nature of a nodule, making it a clear distinction between parathyroid gland and non-parathyroid tissue. It's true for less experienced surgeons, very true, but it's also true for experienced surgeons. I can guarantee you that we sometimes miss some parathyroid glands. And it can help making the distinction between normal and abnormal parathyroid tissue. It could help find a gap and therefore an adenoma. And in parathyroid surgery, it can help find the most normal parathyroid gland in subtotal parathyroidectomy, for instance. So I mentioned the main limitation of autofluorescence. It does not give you any clue on the parathyroid gland viability, and it's the reason we need another tool to detect the parathyroid gland vessel and to make sure that parathyroid glands are still well vascularized after thyroidectomy. And for that, we can use indocyanine green. That is a dye that you inject intravenously that stays into the vessel and that has a strong fluorescent signal. I don't want to spend too much time on our studies, but you probably know that we have published our preliminary study in 2016, showing that or demonstrating that having at least one well-perfused parathyroid gland with ICG perfusion at the end of thyroidectomy allowed to guarantee the absence of hypoparathyroidism on postoperative day 1. Or in other words, having at least one well-perfused parathyroid gland was enough to have measurable levels of PTH on postoperative day 1. This is in our preliminary study with 30 patients. And we described our ICG score of 2 when parathyroid glands are well perfused after thyroid resection, like here, like Vittal, and a score of ICG 0 when they are not perfused after thyroid resection, like here, even making a small incision, there is no white or no green, no ICG coming here, and giving a score of ICG 1 for everything that was in between, a little bit gray, not well perfused, but not completely devascularized. We published our randomized study in 2018, and in this study we could confirm with 150 patients that one well-perfused parathyroid gland was sufficient to avoid hypoparathyroidism on postoperative day 1. None, 0 of those 150 patients developed hypoparathyroidism on postoperative day 1 of those who had at least one well-perfused parathyroid gland. And we could avoid giving or measuring calcium and PTH measurement in half of those patients without having any trouble postoperatively. It seems trivial, but I think every thyroid surgeon in the world will make at least one dosage of calcium and or PTH postoperatively. So I think we were the first ones to demonstrate that it was safe to make a thyroidectomy, total thyroidectomy, without any postoperative measurement of calcium and or PTH, with the condition that at least one parathyroid gland was well perfused with ICG perfusion assessment at the end of the operation. As you know, we all have 4 parathyroid glands, and one of the problems with, or one of the limitations of these studies is that you cannot correlate the perfusion of one parathyroid gland with PTH levels, because PTH level on postoperative day 1 or even intraoperative is the reflection of the production of all 4 parathyroid glands. So we try to have a correlation between the ICG status or ICG scale of all 4 parathyroid glands and PTH levels, and we could also show that there is some correlation, not an excellent one, but there is some correlation between the added score 0 to 8 and PTH levels on postoperative day 1. I just show you a few video examples. This parathyroid gland after thyroid resection, and you see that after ICG injection, this parathyroid gland is very well perfused and will produce PTH. Another example here where you see both views, this autofluorescent view now, and now ICG is injected, and you will see that both parathyroid glands are indeed well perfused, and that this patient will not develop hypoparathyroidism here and here. This is the superior parathyroid gland I have shown you before, and so autofluorescence view again, and this is after thyroid resection. You will see ICG will come, sometimes here. So the inferior parathyroid gland is here, and you see ICG is coming into that parathyroid gland that is well perfused. And the superior one is not as well perfused as we thought, because you may have seen, but it was not the superior parathyroid gland, but just a vessel next to it. So sometimes the evaluation of those perfusion is not that easy, but with some experience you are quite confident that you evaluate really the parathyroid gland you have left and not the surrounding tissue or surrounding vessel. Of course, it's not always as good. You've seen here the autofluorescence view of that parathyroid gland that was, we thought, well preserved. And you see the ICG is coming, however, and unfortunately, this parathyroid gland has been preserved without its vessel, and it's not well perfused at the end of the thyroidectomy. At least you know what happens. For us, it has helped decrease the rate of postoperative day 1 hypoparathyroidism defined as a low level of PTH. And we see 10 years ago, we had about 13% of hypoparathyroidism on postoperative day 1. Now we are around 2 to 3%. And why? Because we changed a little bit our technique, understanding where the vessels run. Once again, it's an anatomical example from Dhalapathy, and you see that if you do a standard thyroidectomy, staying close to the thyroid gland, you will damage both of these parathyroid glands. So you have to take extra steps to stay closer to the thyroid gland, sometimes into the thyroid capsule, to make sure that you preserve those parathyroid vessels. Another example here, you see this is a superior parathyroid gland here that you might not see very well, but if you inject ICG, you see that the tiny vessel feeding this parathyroid gland is here, but you can also see that there are thyroid tissue until here, so if you do your thyroidectomy this way, staying too close to the parathyroid gland, then you will probably, or most probably, damage that tiny vessel. So in conclusions, in our hand, we think that autofluorescence can help detect parathyroid glands. ICG angiography can help protect parathyroid glands and their vessels during dissection, and therefore help predict the absence of hypoparathyroidism. And in our hands, fluorescence technique helps decrease the rate of post-thyroidectomy hypoparathyroidism. Probably you all know that Halstead and almost all the other surgeons wrote that the fact that these little organs perform so highly important function is sufficient reason for the endeavor to preserve all of them. And Paul has worked with me when we were in Lille together, probably he told you, with Charles Poix, and he always taught us the same, that we should fight for each parathyroid gland as if it were the last one. Honestly, I think the new data that we show and that we develop suggests that we should fight not only for all of them, but we should fight more for at least one of them to make sure that we keep at least one well vascularized. Because until now, every thyroid surgeon has fought for all of them, but with the disappointing results that we have mentioned at the beginning of this talk. What is the future of those fluorescent techniques? First, there are some reports showing that the nerves are fluorescent, not in the near-infrared range, but in the UV range. We'll see whether we can use that in clinic. I've shown you that artificial intelligence can help sometimes, and it could help detect abnormal parathyroid gland. This is the team of Aaron Berber in Cleveland, and they use autofluorescence signal to predict whether a parathyroid gland is normal or abnormal. There are other tools without dye trying to evaluate the perfusion of the parathyroid glands, because as you have seen, and I hope I was able to demonstrate that it was very useful to make sure that the perfusion is good and not only the parathyroid gland themselves. But some teams develop laser speckle imaging to try to evaluate the perfusion of the parathyroid gland. It works a little bit like Doppler sonography. So if you have blood cells in movement, the laser speckle image will be different than if they are still. And so you should be able to analyze the perfusion of a parathyroid gland, and you see that the images are clearly different. Well-vascularized glands look like this, non-vascularized glands look like this with a laser speckle, and it might be some development without dyes, or without having to inject anything, including ICG. However, it's still difficult to manage because it's very sensitive to motion, and then you cannot take it in your hand because it moves too much, so there are some limitations. Another laser speckle imaging. Here another laser speckle again. And of course, we all dream of having smart glasses or augmented reality where we could see the parathyroid glands and their vascularization through our standard glasses or standard loops. So in conclusion, I think you can fly safely with just a few instruments, like here, just 5 instruments are enough to fly safely. However, if you are going on a plane, probably you prefer that the pilot has a little bit more information than those 5 instruments you have before. And I think we have new tools that we can use in the operating room for the safety and security of our patients. So I thank you for your attention, and for those of you who are interested in those techniques, be aware that we will hold our 5th symposium on parathyroid fluorescence in Geneva next year, February and 2023. And if you have any questions, please ask them live now, or don't hesitate to send me an email and I will get back to you. I thank you for your attention.
Hello, Frederic, can you hear me? Okay, good, we can see you. The audio is not on? Okay, no, we can't hear him. So thank you very much. That was really a beautiful exposition of the issues and the current status. I think there's a lot of ideas there for us. Many of us are into this, and thank you for your leadership in this area. Actually, normally we don't take questions, but he has kindly consented. If there are any questions, he'd like to take a couple. That's fine. Please, yes, Smita.
The augmented reality glasses that he mentioned, how different is the clarity as compared to the routine loops?
So I think that was only wishful. Are there any augmented reality glasses at the moment
No, he
or
spoke
in development?
about it. He showed the